I couldn't find one. Last night I was getting my feet rubbed by the baddest bitch. Not Trina, but I swear to God, this bitch will make you call your girl up and tell her, hey, what's good? Sorry, I'm never coming home, I'ma stay for good. Then hang the phone up and proceed to lay the wood. I came fast like 911 in white neighborhoods. Ain't got no shame about it. She think I'm spoiled and I'm rich cause I can have any bitch. I got defensive and said, nah, I was the same without it. But then I thought back to a better me. Before I was a B-list celebrity, before I started calling bitches so heavily. Back when you could get a platinum plat without no melody, you wasn't sweating me. One time for my LA sisters, one time for my LA hoes. Lame niggas can't tell the difference. One time for a nigga who knows. Don't save her, she don't wanna be saved. 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 I want a real love, dark skin and Aunt Viv love. That Jada in that weird love. That leave a toothbrush at your crib love. And you ain't gotta wonder whether that's your kid love. Nigga, I don't want no bitch from reality shows. Out of touch with reality hoes. Out in Hollywood bringing back 5 or 6 hoes. Fuck them, then we kick them to the door. Nigga, you know how it goes. She deserve that, she a bird, it's a bird trap. You think if I didn't rap, she would flirt back. Taking off a skirt, let her wear my shirt before she leave. I'ma need my shirt back. Nigga, you know how it goes. One time for my LA sisters, one time for my LA hoes. Lame niggas can't tell the difference. One time for a nigga who knows. Don't save her, she don't wanna be saved. Don't save her, she don't wanna be saved. Don't save her, she don't wanna be saved. Don't save her, she don't wanna be saved.
There's an old saying in Tennessee, I know it's in Texas, probably in Tennessee, that says, fool me once, shame on you. If fool me, we can't get fooled again.
Fool me one time, shame on you. Fool me twice, can't put the blame on you. Fool me 3 times, fuck the peace sign. Load the chopper, let it rain on you. Fool me one time, shame on you. Fool me twice, can't put the blame on you. Fool me 3 times, fuck the peace sign. Load the chopper, let it rain on you. My only regret was too young for Lisa Bonet. My only regret was too young for Nia Long. Now all I'm left with is hoes from reality shows. Hand her a script, the bitch probably couldn't read alone. My only regret was too young for Sade Adu. My only regret could never take Aaliyah home. Now all I'm left with is hoes up in Greystone with the stale face cause they know it's they song. She shallow with the pussy G. Shallow. She shallow. She shallow with the pussy G.
What's good? What's good? Let me see.
She shallow with the pussy G.
Does this look better if I keep this black right here? Or should I have this purple? I don't know. I'm gonna keep this black for now.
I know heaven is a mind state. I've been a couple times. Stuck in my ways, so I keep on falling down. Keep on falling down. Keep on falling down. I know heaven is a mind state. I've been a couple times. Stuck in my ways, so I keep on falling down. I keep on falling down. Yeah. Give me drink, give me smoke, give me high, let me float. I'm a clown, coming down, put me down, gentle now. Give me drink, give me dope. Bottom line, I can't cope. If I die, I don't know, I don't know, I don't know. Give me drink, give me smoke, give me high, let me float. I'm a clown, coming down, put me down, gentle now. Give me drink, give me dope. Bottom line, I can't cope. If I die, I don't know, I don't know, I don't know.
Yeah, I got some niggas that still owe me an apology. I'ma be the bigger man just like I always be. Eventually, but right now that's hard for me. I'm dreaming violent, I can't tolerate disloyalty. So I'ma see you when I see you, know that day coming. I pray that on that day you slip and say something. I never fantasize about murder cause I'm still sane. But I can't seem to fight this urge to make you feel pain. I know that vengeance is the Lord's and it's not for me. I know the punishment for you is that you not with me. You place your value on the bitches that you got with me. And now them bitches ask you daily why you not with me. I had to cut some people off cause they was using me. My heart is big, I wanna give too much and usually I send the bread and don't hit back for like 2 months now. You hit my phone, you need a loan, oh I'm a crutch now. I had to learn, I never had shit. You never would split, you was hood rich. I couldn't get $1 from you, I remember that. It was blurry for a while, but now it's coming back, coming back.
Time will tell who is on my side. Time will tell just who is on my side. I mean well, I can't stop my pride. I mean well, but I can't stop my
Pride.
Give me drink, give me smoke, give me high, let me float. I'm a cloud, coming down, put me down, gentle now. Give me drink, give me dope. Bottom line, I can't cope. If I die, I don't know, I don't know, I don't know. Give me drink, give me smoke, give me high, let me float. I'm a cloud, coming down, put me down, gentle now. Give me drink, give me dope. Bottom line, I can't cope. If I die, I don't know, I don't know, I don't know. Keep on falling down. Keep on falling down. Keep on falling down. I know heaven is a mind state. I've been a couple times stuck in my ways, so I keep on falling down. I keep on falling down. Yeah. Time will tell who is on my side.
Time will tell just who is on my side.
I mean well, I can't stop my pride. I mean well, but I can't stop my pride. Give me drink, give me smoke, give me high, let me float. I'm a cloud, coming down, put me down, gentle now. Give me drink, give me dope. Bottom line, I can't cope. If I die, I don't know, I don't know, I don't know. Give me drink, give me smoke, give me high, let me float. I'm a cloud, coming down, put me down, gentle now. Give me drink, give me dope. Bottom line, I can't cope. If I die, I don't know, I don't know, I don't know.
Remove. I'm about to try this album right here by Death Brian. Excuse me. Let me just double check, make sure stream is working. Where's Chloroquine? gonna take my medicine. Okay, I need to watch some milestones videos. Let me see. The Dirty Dog.
What's up, everybody? Dirty Medicine here. What if I told you that I could teach you the developmental milestones in under 5 minutes? Would you believe me? Or would you insist, no, I cannot learn that in under 5 minutes. I'm not studying that. I'm not going to learn that for the test because it's just too much information for me to know. Well, let me prove you wrong. Before I get into today's video, please consider clicking the join button. You can find that join button underneath any video on my channel. It's also the first link in the description of any video on my channel. And when you click that link, you'll sign up to be a Dirty Medicine member, where you'll pay $4.99 a month in financial support of my channel. I really appreciate your consideration. Now let's get into today's video. So, developmental milestones. The worst topic to study, without question, for step 1 and level 1, but I'm going to teach it to you in under 5 minutes. So let's get started. So with all of these milestones, you need to know what's happening at 2 months, 4 months, 6 months, 9 months, and 12 months. All right, so we'll start with language. At 2 months old, babies can coo. At 4 months old, they can laugh. At 6 months old, they babble. At 9 months old, they can say mama or dada. And when they're 1 year old, they know at least one word. So this is really easy to remember because for language, you just look at the number of letters in each of these milestones. So at 2 months old, they coo, C-O, that's got 2 letters. At 4 months old, they laugh, they say ha-ha, that's got 4 letters. At 6 months old, they babble, babble has 6 letters. At 9 months old, they can say mommy, dada, that's got a total of 9 letters. And when they're 1 year old, they can say 1 or more words. Done. Gross motor. At 2 months old, they can raise their head. At 4 months old, they can roll over. At 6 months old, they can sit up. At 9 months old, they can crawl. And at 12 months old, 1 year old, 2 months old, they can raise their head. At 4 months old, they can roll over. At 6 months old, they can sit up. At 9 months old, they can crawl. And at 12 months old, they can walk. Now, the way that we're going to memorize this is with a Dirty Medicine song. Now, it's been a very long time since I've sung a song for you guys, and I would like to apologize for my absolutely terrible, awful, disgusting voice. But to the tune of Happy Birthday, here we go. 2 months old, raise your head. 4 months old, roll over, Fred. 6 months sit up, 9 months crawl, 12 months walk, and that's all. How easy is that? Let's sing it one more time just to really get it into your memory.
2 months raise your head. 4 months roll over, Fred. 6 months you can crawl. 6 months sit up, 9 months crawl. 12 months you can walk, and that's 12 months walk, that's all. 2 months raise your head. 4 months roll over, Fred. 6 months sit up, 9 months crawl. 12 months you can walk now. 2 months raise your head. 4 months roll over, Fred. 6 months sit up, 9 months crawl. 12 months walk, and that's all.
2 months old, raise your head. 4 months old, roll over, Fred. 6 months sit up, 9 months crawl, 12 months walk, and that's all. Done. Social. At 2 months old, they can twinkle, which means to smile. At 4 months old, they can focus on which direction sound is coming from, so they orient to sound. At 6 months old, they have stranger anxiety. At 9 months old, they respond to their name. And at 12 months old, they respond to commands. So this is really easy to remember because you look at the first letter in each of these milestones. So at 2 months, they twinkle. At 4 months, they focus. At 6 months, stranger. At 9 months, name. And at 12 months, they can be told commands. Now, I don't have a great mnemonic to remember the fine motor skills, but this is 75% of what you need to know, and I've just taught you that in under 5 minutes. So come back to this video, watch it a couple times. This is probably good enough. Hope you didn't mind my awful voice. Good luck. Keep up the good work.
They could have went a little farther.
medical students really hate studying bone tumors. I think this is because there's a lot to know about the different tumors, and a lot of them have different radiographic findings. A lot of them occur in different age ranges, occur in different parts of you need to know to sit for USMLE or CONLEX. Knowing the most basic but yet high yield information, this is the video for you. So when we talk about bone tumors, it would make sense if we conceptualize bone tumors into benign tumors, which will be shown on the left side of the slide in red, and malignant tumors, which will be shown on the right side of the slide in blue. Benign tumors will include osteochondroma, osteoma, osteoid osteoma, osteoblastoma, chondroma, and giant cell tumors. The malignant tumors, well, there's only 3 of them, and they will include osteosarcoma, chondrosarcoma, and Ewing sarcoma. Now, part of the reason that medical students get so overwhelmed in this topic is because if you're looking at this slide, you'll probably notice that a lot of these things sound the same. A lot of them have osteo in the name, a lot of them have oma in the name, and remembering which one does what is part of the confusing problem. So where relevant and where applicable, I'm going to point out what certain words mean in terms of the prefix or the suffix so that you can get an appreciation for the language that we're talking about. So let's just dive in. We're going to start with the benign tumors. We're going to start with osteochondroma. Osteochondroma occurs in males usually less than 25 years old, and it will be located in the metaphysis. The really important thing that you need to know about osteochondromas is that they're the most common benign bone tumor, the most common. That's a very important epidemiological question. They are the most common. They feature what's termed lateral projective growth. So you look at the image here, you see where that red arrow is pointing. Osteochondromas are these little lateral buds off of the metaphysis. And what you'll notice is that if it's described to you in a vignette, it will have either lateral growth or some type of budding off described in the question. And these little buds are covered by a cartilaginous cap, as you might expect, because con equals cartilage. So osteochondroma, the con means cartilage. Now, I want you to look at the word, because if you break down the word, it makes perfect sense what we're dealing with here. Osteo means bone, con means cartilage, and oma means swelling or mass. So we're talking about a bony... cartilaginous mass, and it should make sense. You've got a lateral projection growth which is covered by a cap occurring in the bone. So the name name osteochondroma should make perfect sense to you. But if you're going to take one thing away from osteochondromas, again, it's that you need to know they're the most common benign bone tumor. And because of that, my mnemonic to remember osteochondroma is osteochondroma, because you need to know it's the most common benign tumor. Let's move on to the osteoma. The osteoma occurs in middle age, and it's usually found in facial bones. It has a high yield association that you need to know. It's associated with Gardner syndrome, and we'll touch on this in just a second. It features obstruction of the ostium. So some people will present with osteomas with like a sinusitis type picture, a sinus headache or sinus pressure in the face, in the facial bones, and that's due to the tumor's obstruction locally of the ostium. Now, my mnemonic for remembering osteomas is osteoma in the garden. So I imagine somebody meditating in their garden. And the reason I do this is because Gardner syndrome is the high yield association with osteomas. So if you recall, Gardner syndrome is a whole spectrum of different tumor growths, and one of those tumors that you've probably seen in your list of tumors that Gardner syndrome causes is bony tumors. And this is the bony tumor that it causes. It causes the osteoma. So think about somebody meditating going in their garden. So osteoma in the garden. That reminds you that osteomas are associated with Gardner syndrome. So very, very, very high yield association. Please know that. So if we look at our flowchart, we've done 2 of the benign tumors already. We're cruising. You guys are learning. You know high yield information. Let's move on to the osteoid osteoma. So this is confusing because it sounds like an osteoma. We're just planting the word osteoid in front of it. Osteoid osteomas are found in males, usually younger than 25 years old, and the location of those tumors will be in the cortex of long bones. The findings and what's really important to know about osteoid osteomas are that you have nighttime bony pain, and this is in fact pain that's relieved by NSAIDs, and that's going to be very, very high yield when we differentiate that as compared to osteoblastoma. Now, what you'll see on a radiograph is a bony mass with a radiolucent core, and what that's going to look like is this. So it's sort of this little bubbly thing. It's like a punched out radiolucent core, and you'll see that little teeny circle, and that will tell you that you're looking at an osteoid osteoma. Now, let's compare and contrast the osteoid osteoma with something that's incredibly similar to it, the osteoblastoma. So luckily, these are going to be identical, right? The osteoblastoma is also found in males less than 25. It's found in the vertebrae. It has nighttime bony pain. It has a bony mass with a radiolucent core, so it's going to look exactly like the osteoid osteoma. The only difference is that this is not relieved by NSAIDs. So the pain that comes with osteoblastoma is not relieved by NSAIDs. So again, the high yield information to take away from this discussion is that when we compare osteoid osteoma to osteoblastoma, because they'll present similarly, because they look pretty much the same radiographically, the one
one major difference is that osteoid osteoma is pain relieved with NSAIDs and osteoblastoma is not. So my mnemonic for remembering this is, oh, that feels better. Oh, for osteoid osteoma, which tells you that pain is relieved by NSAIDs. And for osteoblastoma, you get blasted with pain because that pain cannot be relieved by NSAIDs. That's the high yield difference here. Make sure you understand it. So we've now touched on 4 of the 6 benign bone tumors. We are cruising. You're learning high yield information. Let's talk about chondromas. So luckily for chondromas, you really only need to know the location. A chondroma is found in the medulla of small bones, usually the hands or the feet. Don't worry about anything else. This is not a particularly high-yield bone tumor, but I'm putting it here for completeness sake. What you do need to know, which is a very high-yield bone tumor, is the last benign bone tumor, and that's your giant cell tumor. So the giant cell tumor occurs in roughly 20 to 40-year-olds. It's found in the epiphysis of long bones. It's very prominent around the knee area. Now the findings are what make giant cell tumors very, very high-yield. So you've got these, quote, giant cells, and that's where the tumor gets its name from. And the giant cells arise from the bone marrow. This type of tumor causes significant pathological fractures. The 2 really, really high-yield things to take away from this are the soap bubble appearance on the X-ray, as well as the pathophysiology here, and that's the mononuclear rank L expressing cells. So let's first talk about this whole rank L business, because it's really important to understand this. You've got osteoblasts, and on the osteoblasts you have a rank ligand, which is called rank L. And what rank ligand does is it looks for rank and it binds to rank. And what that happens to be on is rank happens to be on osteoclast. So literally your osteoblast will approach the osteoclast, the rank ligand will bind to rank, and when that happens, you get activation of osteoclast, which is part of the pathology here in a giant cell tumor. So you've got these mononuclear rank L expressing cells, which causes pathological tumor growth. Now, the soap bubble appearance is what you see on this slide. That's very, very high yield. As you've probably seen already today, these x-rays all look different. So on USMLE, on Comlex, you can simply be given an x-ray, told that the patient has bone pain, and you'll have to figure out which tumor it is based on the image. So this is a giant cell tumor and has what's called a soap bubble appearance. My mnemonic for remembering this is don't drop the soap or else you'll get a giant surprise. Enough said. So that's all of the benign bone tumors. I hope that you guys feel comfortable with them.
Crazy.
I tried to differentiate the very high yield information, compare and contrast where appropriate, but they're not terrible to memorize. You just really need to know the 1 or 2 really high yield facts from each of those tumors because that is the material that will get tested quite often. Let's switch gears and talk about the malignant tumors. So luckily there's only 3 that you need to know, so not that much information. Osteosarcoma is our first malignant tumor. This classically occurs in young teenage males. It may also be seen later in life in the elderly, but that is less common. The location of the osteosarcoma is the metaphysis of long bones. And there are certain risk factors for osteosarcoma. They include retinoblastoma, Paget disease, Lee-Fraumani syndrome, which I didn't include on the slide, but I believe I did in a couple slides from now, and radiation. The highest yield thing to take away from osteosarcoma, there's technically 2. 1, remember the genetic association with retinoblastoma. It's kind of random because retinoblastoma you classically think about as an eye tumor, but it's associated with the bone tumor of osteosarcoma. So that's very, very high yield. The second thing is that sunburst appearance. So again, I'm going to repeat myself because it's very important. Radiographic images of these bones are the highest yield thing of this entire lecture. So know what it looks like. And this is what a sunburst appearance looks like. I don't know that I would call it a sunburst pattern, but that's how it's described. So if you see this is osteosarcoma. It features this sunburst appearance and lifting of the periosteum if you were to inspect the bone under a microscope. But this is what you need to know, and there you have it. I did write Lee-Fraumani syndrome on this slide. But know the association with retinoblastoma, know the description of sunburst appearance. My mnemonic for remembering that is instead of saying osteosarcoma, I say osteosarcoma on a starburst. So starburst candy reminds me of the sunburst appearance. Starburst, pretty much the same thing. And osteosarcoma, you suck on a starburst, it's very juicy and flavorful. Osteosarcoma reminds me of osteosarcoma. So I remember which tumor has the burst appearance or the sunburst appearance. So that's osteosarcoma. Just remember the appearance again. And remember the association with retinoblastoma. Chondrosarcoma. Chondrosarcoma, really not a lot to know here. It's another, for whatever reason, the ones with chond in the name are just lower yield. Just know the location. It occurs in the medulla of the pelvis and the central skeleton. Don't worry about any associated findings or any associated epidemiology. That's it. The last tumor we need to talk about is the highest yield malignant tumor, and that is the Ewing sarcoma. So Ewing sarcoma will occur in white boys, usually in their teenage years, younger than 15 years of age. It occurs in the diaphysis of long bones. Okay. Now the really high yield part about Ewing sarcoma is what you see here under findings. So 1, on an X-ray, it has an onion skin appearance, and I'll show you an image in just a second. Histologically, you're going to see neuroectodermal originating small blue cells that resemble lymphocytes. That's a mouthful, but that's the phrasing that will be given to you. So it's going to be small blue cells resembling lymphocytes that are neuroectodermal in origin. And the highest yield thing of this entire discussion is the translocation. It's between 11 and 20.
What's up, everybody? Dirty Medicine here. What if I told you that I could teach you the developmental milestones in under 5 minutes?
Goodness gracious.
3 months is to use the 3-letter word coo. So whenever you think of 3 months, you should automatically think of coo. By this age, the infant makes cooing sounds. They also start to smile at people and make eye contact. They begin to recognize your voice, and they may even stay quiet or smile when spoken to. They're going to cry differently for different needs. For example, if they're hungry versus tired, those crying sounds might be different. And they also vocalize pleasure and displeasure sounds differently. For example, they laugh and giggle as a way to communicate happiness, and they cry and fuss as a way to communicate when they're upset. I do want to point out that as we walk through these different milestones, remember that they're average time frames and that some milestones can occur sooner or later. But for the purposes of this video, these are the milestone time frames that may come up on medical exams. Next, we have 6 months. Again, we're going to use the age to remember the milestone. So for 6 months, remember the 6-letter word babble. By this age, the infant starts to babble and repeat sounds. They may babble mama or dada without much meaning, and that's because the repetitive consonant sounds they tend to produce first when babbling are B, D, G, M, P, and T. The infant will also continue to giggle and laugh more. They'll start to make gurgling noises, and they will also use their own voice to express pleasure and displeasure. This is different from 3 months. Remember, at 3 months, they would use laughing, crying, and fussing to vocalize and communicate pleasure versus displeasure. Well, by 6 months, they may start to use their own voice and use speech like babbling sounds to express when they're happy or upset. Finally, the infant notices and recognizes sounds more. They may move their eyes in the direction towards sound, they may pay attention to music, and they respond to changes in the tone of your voice. Moving on to 9 months, we're going to use the age again to remember the milestone. The 9-letter word to remember for 9 months is imitation. This is the start of the baby's imitation phase. They will imitate speech and non-speech sounds, and they will also imitate actions and gestures. They may gesture without being prompted to by pointing to objects and showing them to others. They also look at familiar objects when someone is talking about them, and the infant starts to recognize their own name. The baby's babbling increases, and they start to string longer babbling sounds together. Next is 12 months of age, and using the age, we're going to take the 1 and 2 and 12 to remember 1 to 2 words. By 12 months of age, the child usually can say 1 to 2 words. This could be in addition to mama and dada, and their vocabulary could be even larger depending on the child. Their use of mama and dada has more meaning to it now. Remember, during the babble phase, they can say mama and dada without much meaning. However, by 12 months of age, they start to bring meaning to it. You can also think of the 12-month milestone as the understanding phase, and you can remember that using the 12-letter phrase, understand me. They begin to understand anywhere from 3 to 50 words. They begin to bring meaning to their vocabulary. They begin to understand simple phrases, instructions, requests, and commands, such as put the toy on the ground, come here, and don't touch.
Me has 12
Along those
letters.
same lines, the child may start to understand and answer simple questions non-verbally by nodding and shaking their head. Or they might go to get an object when requested to do so, which makes sense because again, they're starting to understand simple instructions as mentioned before. Finally, they understand and recognize the names and words for common items such as ball, shoe, cup, juice, and dog. This understanding phase is a process, and everything listed here won't happen right at 12 months of age. However, 12 months is when they start to develop these speech and language skills, and they continue to develop those skills throughout their second year of life. As we move on to 18 months, we can again use the age to remember the milestone of 18 words. This will help you remember that by 18 months, the child on average will have a vocabulary of 10 to 20 words. Around 18 months or soon after, the child may have a word spurt in which their vocabulary drastically increases to 50 words. The child also starts to repeat words overheard in conversation. They also become more interactive with their understanding. They recognize and point to familiar objects and people in pictures. They point to pictures in a book when you name them, and they point to familiar body parts like eyes, ears, and nose when you ask. As we mentioned before, with 12 months, they continue to develop their understanding and ability to follow simple commands like put the toy down or roll the ball. And they continue to understand more simple questions like where's your cup or where are your shoes. Next, we have 2 years of age. The 2 can be used to remember the milestone of 2-word phrases. The child will begin to use 2-word phrases in order to talk about or ask for things. They will put 2 words together like more milk, no juice, or daddy book. Then they will ask 2-word questions like where's doggy, where's kitty, go bye-bye, or what's that. Keeping in line with using the number 2, you can remember that by 2 years of age, they will start following 2-step directions, such as pick up your toy and give it to mommy. They may have a vocabulary of 50 words or more, however the pronunciation is often unclear. The parents and primary caregiver usually can understand at least half of the speech. The child may also use gestures and words during pretend play, and they also start to make animal sounds. Moving on to 3 years old, we can use a similar trick as we did for 2 to remember 2-word phrases. Now for 3 years old, we'll remember 3-word phrases. The child will begin to use 3-word phrases in order to talk about and ask for things. By age 3, the vocabulary can be 200 words or more. And not only does their vocabulary expand, but their grammar and pronunciation also improve. Their speech becomes more clear, especially to the parents or primary caregiver. They begin to ask what and where type questions, and they understand spatial concepts such as in, on, or under, as well as concepts involving different colors and time. The child will understand and use more pronouns such as you, me, him, or her, and they will also understand and use plurals such as cats, dogs, shoes, and socks. Finally, we have 4 years old. The trick to remember this milestone is 4 or more word sentences. The child will use sentences with at least 4 words, and they will also use 4 or more sentences at a time when talking about their day or telling a story. They have a deeper understanding of more abstract concepts, and will understand and ask how and why type questions. Along those same lines, they will start to express their ideas and feelings rather than just talking about the world around them. They talk more about their day and activities at school, daycare, or home. Parents and caregivers will understand most, if not all, of their speech, and strangers can typically understand the child without much difficulty. They typically can identify colors by this age, and this often happens even sooner. And they can usually group objects into different categories such as food or clothes. Now it's time to quiz yourself and see if you can name the milestone trick that correlates with each age. Starting with 3 months, what did we say was the trick to remember? It was the 3-letter word coo to help you remember the infant coos at this age. So for 3 months, always think of the word coo. Moving on to 6 months of age, what did we say the trick was? It was the 6-letter word babble to help you remember the infant babbles at this age. So for 6 months, always think of the word babble. Next is 9 months. Try to name the trick for this. You're going to use the 9-letter word imitation, and this will help you remember the imitation phase in which they imitate speech and non-speech sounds, actions, and gestures. So for 9 months, always think of imitation. Moving on to 12 months, what did we say the trick was? You're going to take the 1 and 2 in 12 months to help you remember 1 to 2 words. The child has a vocabulary of 1 to 2 words, usually in addition to mama and dada. You can also use the 12 to remember the 12-letter phrase understand me, and this will help you remember the child starts to understand words, requests, instructions, commands, and questions. As we progress to 18 months, name the trick for this. It's 18 words, which will help you remember that they have a vocabulary of 10 to 20 words, which rapidly increases to 50 or more words as they approach 2 years old. Next, we have 2 years of age. So what's the trick for this? The trick to remember is 2-word phrases, which will help you recall that by 2 years of age, the child starts to put 2 words together in order to talk about or ask for things. The 2 can also be used to remember 2-step directions.
Let's see what the dirty dog gotta say.
In this video, we'll talk about the different childhood exanthems, which is a fancy way of saying rashes that spread throughout the body. On your exam, this will be a pediatrics type question. And this is very challenging for most students because unfortunately, a lot of these rashes look very, very similar. So as you'll see as we move throughout this video, in order to get these questions correctly, you need to know the buzzwords and the associations, but also the pattern or the timeline through which these rashes spread. So we'll go over all of this. I have lots of easy mnemonics to remember this. And by the end of this video, you'll be an expert on childhood exanthems. Just as an overview, here are the different diseases that we're going to cover. Fifth's disease, hand, foot, mouth disease, roseola, rubeola, rubella, scarlet fever, and chickenpox. So let's just dive right in. This sounds really scary. I hear you. I know that you're a little overwhelmed right now, but by the end of this video, I promise you'll feel ready to answer questions about these different types of diseases. Let's start with fifth disease, also known as erythema infectiosum. The pathogen that causes fifth disease is parvovirus B19. The very high yield appearance that you're going to see on your exam is what's known as a slapped cheek appearance. So you see this image on the bottom of my slide. It quite literally looks like somebody was slapped in the face. There's redness on the cheeks, and it's a very specific rash. It's a very specific redness. It's maculopapular, it's confluent, it's photosensitive, and it's lace-like. It's going to be on the bilateral cheeks. This may or may not be associated with arthritis. So you want to know arthritis, and you want to know that slapped cheek appearance. The way that this works is that the patient will initially have non-specific cold symptoms, so maybe cough, congestion, sore throat. Then they'll develop the slapped cheek rash, and then that rash will spread from the cheeks down to the extremities and the trunk. So that's the pattern through which it moves. The takeaway from this slide is that for fifth disease, you need to know the slapped cheek appearance, and you need to know the association with arthritis. If you get an image like this on your exam, you have to be able to say, oh, it's fifth disease, or oh, it's caused by parvovirus B19, or oh, the complication this patient may experience is arthritis. And so because of that, I need to give you a really useful mnemonic. So fifth disease, fifth for the number 5. There are 5 fingers on a hand, and you use a hand to slap somebody. So when you slap somebody across the face, you're hitting them on the name implies this causes lesions on the hand, on the foot, and on the mouth. What you need to know is that this is caused by Coxsackie virus A. The lesions here are maculovesicular, and again, as the name implies, it's on the palms, the soles, and the oral mucosa. So hand, foot, and mouth appears on the hand, on the foot, and on the mouth. So they got a little lazy when naming this one. It rarely spreads. It can spread, but it's usually going to be limited to the hand, foot, and mouth, which is going to make things a bit easier for you on exams, because if you see pictures or you read the vignette and you know that it's on the hand, foot, and mouth, you already know, oh, it's HFM, it's hand, foot, and mouth. This might be associated with stomatitis, which is a fancy way of saying inflammatory changes in the lips. So while the lesions are on the oral mucosa, if the lips become inflamed, it's because you've got that local inflammation due to those lesions around the mouth. Now, the way that this will work is normally the patient will have a fever, and then approximately 48 hours later, they'll develop the characteristic maculovesicular rash on their palms, soles, and oral mucosa. So no mnemonic here because, again, the name of the disease is hand, foot, and mouth. So it tells you exactly where the lesions are. The only thing you need to memorize here is that Coxsackie virus A is the cause of hand, foot, and mouth. And I don't have a mnemonic. I do apologize, but that's the only thing you need to take away from this. So that is hand, foot, and mouth. Again, if you're taking your exam and the patient has lesions on their hand, on their foot, and or on their mouth, you can just guess it's hand, foot, and mouth. Coxsackie A. That's all you need to know. Let's move on to roseola, also known as exanthum subitum. So roseola is caused by human herpes virus 6. This is a maculopapular lesion that starts on the trunk and then it spreads to the face and extremities. This is also known as sixth disease. You don't really need to know that name. I just put it here for completeness sake. Some of your lecturers may refer to it as sixth disease. Some older physicians may refer to it as sixth disease, but it's roseola. It's exanthum subitum. Now this may be associated with Nagayama spots. Nagayama spots are uvular and palatal rashes as you see in that first image. What's incredibly high yield and important to know for roseola is the pattern and the course of this disease. So the way that this works is that the patient will have a high fever, just a fever usually, that will last for about 3 to 5 days. And then after the 3 to 5 days, that fever falls off and breaks, and then the characteristic maculopapular rash will appear as that fever disappears. So this is incredibly specific to roseola. 3 to 5 days of very high, scary fever, then the fever falls off, and once that fever falls off, the characteristic maculopapular rash appears, usually on the trunk and then spreads to the face and extremities. So you need to know the timeline. 3 to 5 days of fever, then rash. And the way that I memorize this is roseola, I think of a rose. And if you've ever gifted a rose or received a rose, you probably know that after 3 to 5 days, the rose petals kind of die and fall off. So it's a perfect mnemonic because roseola, rose for roseola, rose petals fall off after 3 to 5 days. And that coincides beautifully with the fact that in roseola, the patient will have a very high fever for 3 to 5 days, and then the fever will fall off or break or die, and then the rash will appear. So I want you to think about giving somebody a rose. It doesn't matter if you put it in a vase with water and put it in sunlight. The fever, petals fall off the rose, you probably know, days of fever, then rash. And the way that I memorize this is roseola, I think of a rose. And if you've ever gifted a rose or received a rose, you probably know that after 3 to 5 days, the rose petals kind of die and fall off. So it's a perfect mnemonic because roseola, rose for roseola, rose petals fall off after 3 to 5 days. And that coincides beautifully with the fact that in roseola, the patient will have a very high fever for 3 to 5 days, and then the fever after 3 to 5 days, that course is so specific to this one disease, and that's what's going to differentiate it from the other ones on your exam. So of this whole list, roseola is the one where I want you to know that timeline. 3 to 5 days of fever and then rash. Now we'll talk about rubeola, also known as measles. Most people just call this measles. The pathogen here is the measles virus. The findings are that we have a maculopapular lesion that usually starts on the face and then it spreads downward. So measles or rubeola works top down. Starts on the face, works.
Maculopapular. I feel like I need to understand what the word means. Flat red area. Let's go. A macula is a flat reddened area of skin. Papula, right? Let's see. I love that bass guitar. That bass guitar is going crazy. I already have this in here. It's already there.
Downward. It's associated with the 3 C's, cough, conjunctivitis, and coryza. It may be associated with something very high yield called Koplik spots. Koplik spots are just these spots, as you can see in this image, that appear on the buccal mucosa. So if you see Koplik spots, that is a glaring giveaway that the question is asking you about measles. And this is complicated by pneumonia. So some patients who have measles can develop pneumonia. So it starts with a viral, obviously measles is a virus, it starts with a viral rash, a viral fever, cough, conjunctivitis, coryza, but that progresses into sometimes a bacteria. Bacterial complication of bacterial pneumonia. Very, very high yield for exams is that you give doses of vitamin A to mitigate this. It makes it better. Patients respond well when they receive vitamin A. So the 2 high yield things for measles or rubeola is 1, Koplik spots on the inside of the mouth, on the buccal mucosa, and 2, vitamin A for treatment. And so the way that this will usually present on your exam is that they're going to describe someone who's sick. It's going to be non-specific, it's vague, right? They're going to have cough, maybe a low-grade fever, maybe their eyes are watery. You're not going to be able to know, oh, it's measles. But what they'll do is they'll either describe the Koplik spots or they'll show you the Koplik spots. And then they'll ask you, what's the causative pathogen? Answer being measles. Or they'll ask you, which of the following should the patient receive immediately? And the answer will be something like vitamin A. Now the interesting thing is that this video is all about exanthem. X-anthem, X meaning on the... And 2, vitamin A for treatment. And A. Measles is a virus that starts with a viral rash, a viral fever, cough, conjunctivitis, coryza, but that progresses into sometimes a bacterial complication of bacterial pneumonia. Very, very high yield for exams is that you give doses of vitamin A to mitigate this. It makes it better. Patients respond well when they receive vitamin A. So the 2 high yield things for measles or rubeola is 1, Koplik spots on the inside of the mouth, on the buccal mucosa, and 2, vitamin A for treatment. And so the way that this will usually present on your exam is that they're going to describe someone who's sick. It's going to be non-specific, it's vague, right? They're going to have cough, maybe a low-grade fever, maybe their eyes are watery. You're not going to be able to know, oh, it's measles. But what they'll do is they'll either describe the Koplik spots or they'll show you the Koplik spots. And then they'll ask you, what's the causative pathogen? Answer being measles. Or they'll ask you, which of the following should the patient receive immediately? And the answer will be something like vitamin A. Now, the interesting thing is that this video is all about exanthem. Exanthem, X meaning on the exterior of the body, right? Rashes on the skin. But Koplik spots are actually an example of the opposite of that. They're an example of an N-anthem, N meaning inside the body, on the interior. So I say that to point out that, yes, these are exanthems, but they're also associated with N-anthems, and Koplik spots is a really good example of that. Now, for measles to me sounds like mussels. So I think measles marinara as opposed to mussels marinara, which is a delicious dish that everybody should try. But for measles marinara, what does that remind me? This is my mnemonic here. That reminds me of Koplik spots, because if you were to eat measles marinara or mussels marinara, you might get little spots of red inside your mouth because the marinara sauce is there. It also reminds me that the rash starts around the mouth, right? It starts on the face, and it works its way down. So measles marinara, because measles sounds like mussels. That's my mnemonic for measles. All right, so we are four done, only 3 to go, and you're ready to answer questions because you know the high-yield associations already. See how easy this is? Let's talk about rubella. Rubella is also known as German measles. I wouldn't really worry about the name, just call it rubella. The pathogen here is the rubella virus. So this is caused by rubella virus. Now, the findings are a maculopapular lesion that starts behind the ears and spreads downward. So rubella is similar to measles in the sense that it starts somewhere on the head and works its way down. But where I would differentiate rubella from measles is that rubella tends to start behind the ears. So that behind the ear feature, very, very specific to rubella. So if you see ear behind the ear, post-auricular, that is screaming at you that the answer is rubella. So keep that in mind. Now, taking that one step further, what you're going to see is lymphadenopathy that's post-auricular and sub-occipital. Post-auricular behind the ear, sub-occipital generally a little bit down toward the bottom. So if you see the buzzword post-auricular behind the ear or sub-occipital, whether they're talking about the lesion or they're talking about the lymphadenopathy, that is a dead giveaway for rubella. Now, this is usually going to be maculopapular, but the rash that appears on the trunk as we start to see it spreading tends to be a little bit more desquamating. Not very, very high yield, but if you see the word desquamation as it applies to one of these exanthems, you probably want to guess rubella. Lastly, this is associated with something called a Forchheimer spot, which is a way of saying soft palate petechiae. Again, you see an image here. Soft palate petechiae, also known as a Forchheimer spot, that's associated with rubella. So the key takeaway for rubella is, again, behind the ear, because that's where the rash is going to start. That's where the lymphadenopathy is going to be most prominent. So we need to memorize behind the ear for rubella. So rubella has Ella in the name, which reminds me of when you answer your phone, maybe like someone from Australia, you go, hello? Hello? Hello, who's this? So Ella for rubella, or LO for rubella. That's how I memorize this. So that phone is touching the ear. It's touching right behind the ear, which always reminds me that rubella, hello, who's this? That starts behind the ear. The lymphadenopathy tends to be most prominent post-auricularly. All right, that's my dumb mnemonic for rubella. So we've only got 2 more to go, and I've got good news. They get easier. So let's talk about scarlet fever. So scarlet fever is caused by strep pyogenes. And maybe you've covered this if you've already studied the bacteria section. The findings here are that you have a maculopapular sandpaper-like rash that starts on the neck and then spreads outward. Truth be told, I probably should have bolded and put in red the term sandpaper-like, because if you see sandpaper-like rash, alarms have to be going off in your brain that that's scarlet fever. So it's a very unique description. Sandpaper equals scarlet. I just want you to memorize that. The rash has what's known as the Pastia sign, which is linear petechiae in areas of the body where the skin gets creased. So for example, the groin, armpit, the elbows. You see this in the image on the slide on the bottom left. Basically, anywhere there's a fold or a crease, those areas will have linear red lines, and they're actually petechiae kind of lining up. That's known as Pastia sign. Very, very high yield. I've got a mnemonic on that in just a second. Scarlet fever is also associated with strawberry tongue. Again, you may be familiar with this already if you studied the bacteria section and you already went through strep pyogenes. And lastly, the rash and the fever that are associated with scarlet fever is not viral. So bacterial infections tend to come on much more quickly because there's not necessarily a viral prodrome, since obviously it's not a virus. So on your exam, that can be helpful to you if in the vignette they give you the rash and the fever, but tell you that it's a very acute and sudden onset. That kind of points you in the direction of scarlet fever. But again, if you see Pastia sign, if you see linear petechiae, or they describe it as a sandpaper-like rash, then you need to just stop what you're doing and pick scarlet fever. Now, Pastia sign sounds obviously like pasta, so here are very straight spaghetti noodles. The pasta sign or the Pastia sign is linear petechiae, and here I'm showing you some linear spaghetti noodles. Just remember that. Very, very high yield. So the like rash, then you need to just stop what you're doing and pick scarlet fever. Here I am, and that's going to be chickenpox. So chickenpox is caused by the varicella zoster virus. It is a vesicular rash on an erythematous background. Now that is all you need to know for chickenpox. If you see vesicles on a red background or vesicles on an erythematous background, stop what you're doing, do not press go, and click the answer that says either chickenpox or varicella zoster. I mean, look at the image on this slide. You can see, and this image is showing you how the rash evolves over the course of 8 days. You can see that it is a vesicle that eventually crosses over, as vesicles do, and it has that red sort of halo or background around the vesicle. And so vesicles on a red background, vesicles on an erythematous background. If you see that terminology, stop. The answer is chickenpox. So just like in scarlet fever, where scarlet equals
dog. That's why he's a goat.
And here's an overview slide of everything that we're going to cover. We're going to talk about the 4 different types of vaccines, which you see here on this slide. And as I go through this video, we'll talk about the physiology of how these vaccines are working. So we'll kind of describe what's happening on the immunological level. We'll talk about some cautions or adverse reactions that you should be familiar with each of these different types of vaccines. And then maybe even the highest yield part of this video is actually the different examples. So we'll talk about the different viruses and bacteria that have vaccines in each of these 4 categories, because unfortunately on USMLE and Comlex, it's fair game to have to know that information. For example, to know that smallpox is a live attenuated vaccine, but that HPV is a subunit vaccine. So you have to know what type of vaccine each of the different vaccines actually are. And that's what I'm going to go through in addition to just all that background science that you need to know. So let's go through these topics, these different types of vaccines one at a time, and by the end of this video, you'll be an expert on the different types of vaccines, the physiology, and the examples. So let's begin with live attenuated vaccines. So personally, I'm a huge advocate of looking at words, looking at prefixes and suffixes to help you understand what a phrase or a medical term is referring to. And if you didn't know what the word attenuated means, if you look that up and do a Google dictionary search, what that word means is having been reduced in force, effect, or value. So if you know the definition of attenuated and you think about the phrase live attenuated vaccine, it makes perfect sense what these vaccines actually are. So in a nutshell, a live attenuated vaccine is a vaccine that contains a microorganism, and that microorganism can still infect the host technically if it becomes introduced, but generally speaking, it had its pathogenicity taken away. So it's safe to give it in a vaccine because typically we have enough immune response present to not let it go out of control, but it'll induce a humoral and cellular response. And that's what we want as the physicians and the scientists giving these vaccines. Some cautions that you should be aware of with a live attenuated vaccine is that the microorganism technically has the ability to revert back to its virulent form. And what this means is that when you give somebody a live attenuated vaccine, generally speaking, in your normal person who has a normal immune response, this won't happen because you've taken the pathogenicity away from the microorganism. However, if you're going to give this to somebody who's immunocompromised or pregnant, it has the
the ability to go and cause a very dangerous infection. Because even though you've taken away the pathogenicity of the microorganism, that microorganism still does have the ability, technically, to infect the host once it's introduced. So if you were going to conceptualize this, the bottom line here is that the live attenuated vaccines are technically the most risky because they can revert to their virulent form and really cause that infection. And it's for this reason that it's usually contraindicated in pregnant patients and immunocompromised patients. Now that said, the one really high yield thing that you should know is that you can still give a live attenuated vaccine to an HIV positive patient if they're not already immune to one of these live attenuated vaccines. But in order to do so, you have to ensure that their CD4 count is greater than 200. Otherwise, they could really become sick very quickly. Now, what's the highest yield part of today's video? It's knowing the examples of the different vaccines that correspond to each of these 4 categories. So for live attenuated vaccines, what are the examples? Well, they're measles, mumps, rubella, varicella, polio, and specifically the Sabin polio vaccine, adenovirus, the influenza or flu vaccine, but only the intranasal version of it, rotavirus, and smallpox. Now, I know what you're saying. You're sitting there and you're watching this video and you just pooped in your pants and you're like, oh my god, Dirty, I'm never going to be able to learn this list. What the heck, man? Well, it's actually a lot easier than this. So I'm going to reorganize this and give you my mnemonic. So measles, mumps, rubella, varicella, polio, adenovirus, influenza, rotavirus, and smallpox. The way that I've always remembered this, going back years now, is really vivacious pairs of vaccines. Now, why does this work? Well, vivacious means lively, and this is live attenuated vaccine. So my mnemonic with the word vivacious goes with the live attenuated vaccines, because after all, the term vivacious means lively. So really vivacious pairs of vaccines. M&M for measles and mumps, the R in really for the R in rubella, the V in vivacious for the V in varicella, and again, vivacious means lively, and we're talking about live attenuated vaccines. And then pairs, P-A-I-R-S for the P in polio, the A in adenovirus, the I in influenza and intranasal, the R in rotavirus, and the S in smallpox. So when you're sitting there on test day and they ask you which of the following is a live attenuated vaccine, you're going to go live. Lively means vivacious. Really vivacious pairs of vaccines. And you're going to remember exactly what the examples of the live attenuated vaccines are. You're welcome. I just got you all a free point on test day. Crushing it. That's it, guys. That's all you need to know for live attenuated vaccines. Let's move on to the killed, also known as inactivated vaccines. So a killed or an inactivated vaccine, you can see it referred to as either killed or inactivated, means the same thing. In this case, what's happening is you get a humoral response. And typically, they take the pathogen, the scientists do, and the pathogen gets inactivated. And that can happen either through chemical means or like hyperheating something to extreme temperatures. And you heat it or you chemically, mess with it, I guess. I'm not a PhD here. But you change it in such a way that it's inactivated. And when that happens, you get this humoral response. But what's really interesting is that the surface antigen epitope, the maintenance of that epitope is reformed, so the needle, that's killed. And then the Salk subtype of polio vaccine. So again, we talked about one type of polio vaccine, the Sabin, which was in live attenuated, but the Salk polio vaccine is killed. Now, how do you remember this? Well, when you think of someone who's been killed, you think of them being buried in a graveyard, and you say rest in peace, or RIP. So in the killed or inactivated vaccines, these always rest in peace. They always, A for always for the A in hepatitis A, R in rest for the R in rabies, the I in for the I in influenza or intramuscular, and the P in peace for the P in polio. So killed vaccines always rest in peace because they're killed. So when someone's killed, they rest in peace. That's really it. Not that many to know here. Easier to memorize, I would say, than the live attenuated vaccines. But something that's really important that you should take away from this video that's incredibly high yield, don't ask me why, but it shows up all the time, are these 2 different types of polio vaccines. So you've got the Salk and the Sabin. Okay, and you need to know which one is live for the R in rabies, the I eating, and the body's only recognizing the surface antigen epitopes. Now, what are the types of killed or inactivated vaccines? Well, it's hepatitis epitope. You have to maintain it on the surface in order to get that immune response because the body is only seeing the surface of these killed pathogens. Now, what are the cautions here? Well, it requires boosters throughout your life. Boosters are usually required in types of vaccines that are technically weaker. So if it induces a weaker immune response, if you give these boosters because you're trying to boost that immune system every so many years. And again, I've already encapsulated bacteria. Because if you know the 3 encapsulated bacteria that I've already mentioned, S. pneumonia, N. meningitis, and H. influenza type B, you're probably going to get most, if not all of
Need the vaccine schedule, Dirty Dog.
What is going on, wonderful people? This is Medicosis Perfectionist, where medicine makes perfect sense. This is my comparisons playlist. Today's video is a... What is going on, wonderful people? This is Medicosis Perfectionist, where medicine makes perfect sense. This is my comparisons playlist. Today's video is a comparison between neonatal respiratory distress syndrome, which is evil, and transient tachypnea of the newborn, which is kind of benign. With that said, now let's get started. When the baby is born, it's a neonate. If the entire body of the baby is blue, you have 2 possibilities. It could be a respiratory disease or a cyanotic congenital heart disease. How do I tell the difference between heart or lungs? Easy. Try to replace the job of the lung and see what happens. Give 100% oxygen. If it improves, oh, that was the lung's problem, because it was corrected with oxygen. If it did not improve, that's a cyanotic congenital heart disease, such as tricuspid atresia, tetralogy of Fallot, TAPVR, transposition of great vessels, and truncus arteriosus. Let's talk about respiratory problems. It could be a problem in the airways or a problem in the lungs. Problem in the lungs would be respiratory distress syndrome, transient tachypnea of the newborn, meconium aspiration, or persistent pulmonary hypertension. Today we'll compare between the first 2. RDS, TTN, MAS, PPHN. Now we have talked about both of these diseases in detail in previous videos. You'll find transient tachypnea of the newborn video in my playlist called 5-minute review, and you'll find my neonatal respiratory distress syndrome video in my pulmonology playlist. So this is a very quick review. Transient tachypnea of the newborn, the baby is full term, it happens during the first day, probably during the first 2 hours after birth. Basically, there are fluids in the lungs, this is delayed clearance, just give it some time, the baby will clear the fluids and everything will be hunky-dory. Signs and symptoms: transient tachypnea, increased breathing effort, diffuse crackles, maybe diminished respiratory sounds. Diagnosis is clinically, when you do an x-ray, you'll find increased lung volumes and fluid in lung fissures because of delayed clearance. Treatment: self-limiting disease, so don't worry about it, supportive care and supplemental oxygen, and everything will be good, hopefully. Here's the F mnemonic for TTN, it happens during the first day of life. To a full-term neonate, there's fluids in the lungs due to delayed clearance. On x-ray, you'll see fissures filled with fluids. On auscultation, you'll hear here diffuse crackles, and it's a fart in the wind. It's a self-limiting condition. Next, neonatal RDS is caused by the lack of surfactant, and as you know, surfactant is anti-surface tension. How does the pin float on the surface of the water, even though the density of the pin is greater than the density of the water? Easy. Surface tension between the air and the water interface. What do you have in your lungs? I have air, I have water. Oh, so there's an interface and there's surface tension between the air and the water. That's right. This can lead to surface tension. That's true. Surface tension can collapse your lungs. Oops, how can I prevent this? Thankfully, you have a surfactant. You should thank your type 2 pneumocytes. How do I know that the baby has enough surfactant? There's something called the lecithin sphingomyelin ratio. You want it to be 2 or greater. But what if the baby is born immaturely? Well, there was no enough time to make surfactant, especially if mommy has diabetes, because diabetes in the mother will lead to hyperglycemia in the mother, which will lead to proliferation of the beta cells of the pancreas of the baby. The baby will make too much insulin. Insulin is anti-surfactant. C-section can be a risk factor due to lack of stress. Mommy has diabetes, mommy has hyperglycemia. Glucose will flow from mommy to the baby via the placenta. Now the baby has tons of glucose, the baby will react by secreting more insulin from the beta cells of the pancreas. Insulin is anti-surfactant. Insulin is bad for surfactant, but these 3 hormones are good for surfactant. And that's why the treatment of neonatal RDS is to give steroids. Neonatal RDS, there is no surfactant, surface tension will try to collapse surfactant. And that's why
This song is nice. I gotta send this song to my homegirl. No role models? Yes, sir. That's what was on. I don't know if you're still in the chat, Pluto, but yeah, I am. You know, I'm not even doing anything on I am really just focus on peds. I think I'll be good on peds. I did 3 practice tests. I passed 2 of them. I'm taking another one right now. Well, right now I'm watching some videos. Yeah, I was listening to No Role Models earlier. I'm watching some vids. And I'm also like doing questions and then going over the I was doing the IM exam, but I haven't finished it yet. Oops, it's questions. Song is nice too. Yeah, taking a steady break. How are you feeling? Are you doing yeah. What is, do you know the what do you need to pass IM? Like, what's the lowest score you can get? Cause I forgot. Somebody said it's like the lowest of all of the exams. But you know, I don't think it's gonna help me. And I also have to take both exams same day, bro. I have to take peds at 8:30, and then you said IM is at 2. So it's like my stamina is gonna be kind of messed up. I mean, is it gonna be messed up? I mean, it's better than doing 250 questions like step 1, but you know. 52 for IM, 57 for peds. That means I missed peds by 1 point. Let me see. I'm pretty sure I got a 56 on peds. And I tried to ask them if they let me take peds on a different day, but they didn't respond to me. Yeah, I got a 56 on peds. Oh, so did I even fail that third practice test where I only need a 57? Yeah, no, I did. Yeah. Dang, I really missed peds by literally 1 point. That's actually so crazy. Yeah, OB messed me up so bad. Just that stagger. Like I was saying for OB and peds. And now IM. I don't know. If I somehow pass both of these, I don't know. I mean, I'm not passing IM. Like, I haven't even been, like I said, I stopped studying for IM just to, cause I don't want to do peds again. And then when I'm taking psych, then I'll just try to do psych and IM at the same time. But, like, no, I'm not passing IM. I don't know if I hope I'll pass one of these things. Hopefully it's peds more than anything.
The treatment of neonatal RDS is to give steroids. Neonatal RDS, there is no surfactant. Surface tension will try to collapse your lungs. Your lungs are dark and airless. Your alveoli have collapsed, aka atelectasis. Protein is going to leak out of the vessels. Oh, protein is pink under the microscope. That's why we call it the hyaline membrane disease. In neonatal RDS, the symptoms happen within minutes after birth. Early onset tachypnea, respiratory difficulty, grunting, intercostal retractions, maybe acidosis, maybe alkalosis, depending on tachypnea or bradypnea, cyanosis, and maybe intraventricular hemorrhage. Diagnosis: ABG, chest X-ray will show you ground glass and fine reticular granularity, and air bronchograms. Biopsy: hyaline membrane disease. Neonatal RDS is a terrible disease, can lead to glass and fine reticular granularity, and air bronchograms. Biopsy: huyland membrane disease. Maybe acidosis, natal RDS. Protein is going to leak out of the vessels. Oh, protein is pink under the microscope. That's why we call it the hyaline membrane disease. In neonatal RDS, the symptoms happen within minutes after birth. Early onset tachypnea, respiratory difficulty.
Was the OB stuff the same when I took it? No, it wasn't the same. I mean, I actually don't know, but all I know is that test felt mad easy. Like, that mug felt so crazy easy, it was insane to me. But I also did all the OB practice tests. Like peds, I literally only did like 2.5 practice tests for peds. So, you know, so hopefully if I finish all the peds practice tests, then I'll be good. And then IM, you know, I got to get these IM practice tests in. But I guess even for OB, I don't remember how many practices I took for OB, but you know, I didn't do all of them, so you know, I guess I'll try to bust through as many practices as I can. How many of these peds ones I have? I have to finish 5, 4, and 3. Could I do 150 questions and then do more peds? More do IM? Maybe I'll just switch back and forth between peds and IM practice tests. What do you think I should do, Pluto? You think I should just finish these last 3 peds practice tests? 5, 4, and 3, that's 150 questions. And then if I have time or the energy, then do an IM practice test? Or should I finish 5, then do an IM test, and do a peds test and do an IM test? You know, I guess I'll see what happens if I'm passing these or not. Yeah, I am. It really isn't that much different. Let me finish this stupid video.
Grunting, intercostal retractions, maybe acidosis, maybe alkalosis, depending on tachypnea or bradypnea, cyanosis, and maybe intraventricular hemorrhage. Diagnosis, ABG, chest x-ray will show you ground glass and fine reticular granularity, and air bronchograms. Biopsy, hyaline membrane disease. Neonatal RDS is a terrible disease, can lead to death, acid-based disturbances. The doctors will give you too much insulin, which has side effects. It can lead to bronchopulmonary dysplasia, retinopathy of prematurity, etc. And neonatal RDS can keep your ductus arteriosus open. More complications include necrotizing enterocolitis, pulmonary hemorrhage, alveolar air leak causing pneumothorax, edema, ileus, oliguria, etc. How do I prevent it? Avoid unnecessary C-sections. Before birth, give steroids. After birth, give surfactant. Let's compare between the two. Neonatal RDS, preterm baby, but TTN, full-term neonate. What's the cause? Decrease surfactant. What's the cause? Fluids in the lungs due to... Let's compare edema, ileus, oliguria, etc. How do I prevent it? Avoid unnecessary C-sections. Before birth, give steroids. After birth, give surfactant. Let's compare between the two. Neonatal RDS, preterm baby, but TTN, full-term neonate. What's the cause? Decrease surfactant. What's the cause? Fluids in the lungs due to delayed clearance. Risk factors: preterm, male, maternal diabetes, C-section. Here, premature delivery, male sex, maternal asthma, or maternal diabetes, C-section, small for gestational age, or on the contrary, macrosomia. The onset of symptoms within minutes or hours. Here, this within the first 2 hours. Clinically, tachypnea, increased breathing effort, cyanosis, hypoxic, grunting, etc. Here, tachypnea, increased breathing effort, diffuse crackles. Chest X-ray, ground glass, and air bronchograms. Here you have fissures filled with fluid. How do I treat RDS? Give surfactant, and you'll probably need mechanical ventilation, but transient tachypnea of the newborn is self-limiting. Just provide supportive care. Complications of neonatal RDS including patent ductus arteriosus, pneumothorax, bronchopulmonary dysplasia, necrotizing enterocolitis, etc. TTN has no complications in the vast majority of cases. It's a fart in the wind. Let's review neonatal RDS from Picmonic. There is fetal lung immaturity, no complications in...
I forgot what bronchopulmonary dysplasia was. Can I look you up? I'll go on med bullets. How was your knowledge during your iron rotation? Like, did you remember all the diseases and drugs that your patients had? I felt like my knowledge was good. I mean, I could be brushed up on my infectious disease stuff, but and like but I know Sub2 didn't really be asking mechanism like that, but like I know the gist of like every medication, at least that we're talking about on rotation. I'll go. Med bullets. Most common respiratory morbidity in preterm infants. Oh, that's a study. Pull out my stupid Anki. BPD, premature infants exposed to prolonged mechanical ventilation and O2 therapy for respiratory distress syndrome. Main complication of continued treatment for nerds is bronchopulmonary dysplasia. Okay, I see. Oh, I see. Okay, let me look at this vaccine schedule video. Where's my... Okay. That's crazy. I failed Peds by 1 point. That would have been so clutch if I would have passed Peds, bro. That would have been crazy. Oh my goodness. 1 point. Dummy. See, that can't happen with IM, bro. That can't happen with IM. If I fail IM by like 1-2 points.
In the vast majority of cases, it's a fart in the wind. Let's review neonatal RDS from Picmonic. There is fetal lung immaturity due.
No, I need to look at the vaccine schedule. These fools better not screw me over. Step 2. Step 2. I don't want these fools to screw me up. Also, JoJo, you didn't get a chance to eat my how do you say? You didn't get a chance to eat my noodles, bro. My stir fry. I still have it in the fridge. I've been trying not to eat it, bro. I wanted you to try it. I mean, I can always make it again. Still have all the ingredients. But yeah, my stir fry. I literally can't stop thinking about it. How is your knowledge during your IM rotation? Oh yeah, you already asked. Yeah, I read that. You had 59. Yeah. I could have. I just didn't study hard enough. That's the thing. I finished all the Peds UWorld. So that was that, but I didn't do all the practice. If I would have did another practice test, like I said, I missed by 1 point. So a practice would have helped me. So that's just my fault. One thing at a time, bro. Control what you can control and keep working. Yeah, I'm gonna try. My bad, don't want to get chat banned. What did you say? You said some Vegeta mess? Or you tried to call me a monkey or something? Also, bro, how do you like the I got this this Beast MD thing right here. I got some person, they made me a banner for my YouTube. They made me this. This is like, has my name, has my region for Rivals and for Smash, and then has my stuff on here. And so I just put the Beast MD on the stream. And I got this made. I had to pay somebody for this. This is for this video I'm gonna make, not now, but in a few like months. I've had that thumbnail made. Don't want to get, yeah, that's cold. Yeah, I'm saying, bro. But I need to change the colors up, because my profile picture on YouTube is like gold, and so I don't think the purple don't really match as well. And so I'm gonna ask the person if they could like change the colors up. Yeah, let me watch this mess.
on how you can remember all these vaccines. And as always, at the end of this YouTube video, you can access a free quiz that will test you on this material. So let's get started. We will start with birth, and this is super easy. All that's required at birth is the hepatitis B vaccine, and there will be 3 doses given, and the first dose will be at birth. Next is at 2 months, and they will get several vaccines at this visit. They will get the hepatitis B, which will be your second dose, our DTaP, which is for diphtheria, tetanus, and pertussis, the Hib vaccine, which is for Haemophilus influenza type B, which will help prevent against epiglottitis, polio, the pneumococcal conjugate vaccine, which is the PCV, and then the RV vaccine, which is the rotavirus vaccine. Then at 4 months, they will get everything they got at 2 months except the hepatitis B vaccine. So they will get the DTaP, they will get the Hib, polio, PCV, and RV. Then at 6 months, it's really easy because it's exactly what they got at 2 months, which will include hepatitis B, the DTaP, the Hib, polio, PCV, and the RV. And then also at 6 months, they will start receiving an annual flu vaccine. So if you can remember, from 2 to 6 months, they get exactly the same vaccines, and it's 6 of them. But then at 4 months, they will get everything except hepatitis B. Then we move on to 12 to 18 months. So here the child will get
You know
the
what Dr.
DTaP.
Bowman told me to memorize the 12 months? Dr. Bowman said, you gotta go, varicella, Ella, hep A. I still never forgot that.
And they'll get this at the 15 to 18 month mark. And then Hib, PCV, the MMR, which is new, we're adding on, and the varicella, which is chickenpox. And then they'll also get the hepatitis A vaccine, which is going to be required in 2 doses. They'll get 1 dose at 12 months, which is 1 year, and then they'll get the second dose 6 months later at 18 months. And of course, the annual flu shot during flu season. And finally, between 4 to 6 years old, they will get the following vaccines, and there's only 4 of them. So I think that's easy because I remember that it starts at 4 years. So they'll get the DTaP, polio, MMR, and the varicella. And of course, if it's flu season, they'll get the annual flu shot. Now let's go over some mnemonics to help you remember when these vaccines should be given. Okay, at birth, that is easy. They just need 1 vaccine.
I don't even know mnemonic. Where's the quiz? Two-month-old Anita, which of the following? 2-month-old gets no, they don't get that B in 2 months. No, yeah, they do. Then you get Hib, DTaP, polio, rotavirus, this. Varicella, the answer to your question is, she gets varicella at 12 months and 4 to 6 years. When should she receive her first Hep B at birth? 12-month-old receives a series of vaccines, including the Hep A vaccine. When should she receive the second dose of this vaccine? At 4 to 6. A 4-year-old is scheduled for routine immunizations. She's gonna get DTaP. She's gonna get MMR, varicella. I don't know what else. She gets 4. I'll go polio because I don't remember. When do you get rotavirus? Get rotavirus at 2 months and 6 months. 2 for 6. I forgot. What age is a child start receiving a yearly flu vaccine? At 6 months. Free educational clinic to new models about immunizations. He informed the attendee that the MMR is given at 6 and 12, I think. Say, man, they didn't say that mess in the video. Bro.
And then they'll also get the hepatitis A vaccine, which is going to be required in 2 doses. They'll get 1 dose at 12 months, which is 1 year, and then they'll get the second dose 6 months later at 18 months.
Doses of rotavirus. months and 46 years. Okay. Yeah, I'm gonna do that quiz again later. It's a nice quiz. Okay. Alright, I'm gonna use the bathroom. Bad, thank you. You're gonna ask me I am questions or answer when you say I'm gonna break. Okay, bad. I'm about to go use the bathroom, so I'll be right back. And I'm gonna refill my water. And I'm gonna be on break just for a little bit, just because I know, like, because I've been drinking so much water today. As soon as I use the bathroom, I'll have to go again in like 2 minutes. So I'm gonna stay on break for like the next 5 minutes or so. I'm black. This song is leaving playlist. Tired of that one. Forgot to get water. Maybe that's what's in the cup. You don't even know what's in here at all. Who knows what's in this cup? But you know what I got in this one. Green juice, my boy. Veggie power, my boy. Cucumber, celery, grapefruit. Chard. What is chard? Lettuce, limon. 35 calories. 5 grams total sugar. It's not bad. Some juice. What in the world is chard? Hold on. Is a cruciferous. Oh, this is what chard is. Wow. Is it the same as collard greens? It's not kale. Interesting. Excuse me. Infant with tachycardia, hypotension, delayed capillary refill, and acute onset diarrhea. Consistent with diagnosis of gastroenteritis associated volume depletion. Kids are at an increased risk of volume depletion in comparison to adults in gastroenteritis. Diarrhea of significant stool loss of bicarbonate, which in combination with hypoperfusion in the organs with lactic acidosis may result in metabolic acidosis. Urinalysis shows aciduria and an increased respiratory and increased urinary specific gravity. gotta get on his phone. Neilman again, bro. Neo congenital. Randy Neo.
Alright guys, so this video is about the adrenal cortex questions. You know, when I was studying through this, I always had trouble knowing the 11 versus 17, 21 hydroxylase. So if you understand the pathway, I know there's a way to memorize it, but if you understand the concept behind it, I don't care how they would ask you the question forwards, backwards, upside down, doesn't matter. Is that if you learn it this way, the way we're going to teach you in a second, I think you'll be prepared for any question they could ask. Alright guys, so, okay, and it goes like this. And we know the first, you know, obviously the first layer is the glomerulus, okay? And then we got the vesicular layer, okay? Let's go on that. And then we got the reticularis, okay? And they always say, you know, the sweeter it is, and we go in, all that kind of good stuff. But GFR, right? So we have to know where those enzymes, right? It was the 21 hydroxylase, the 17, and then the 11. So it's real easy. And the key with this is you got to know the concept behind it. And I don't care what kind of question that they ask us. So again, adrenal cortex, everything's stimulated by ACTH. And if you come down to the glomerular layer, you know, we're dealing with aldosterone, okay? Dealing with aldosterone, and you got it. And here's the key. I can't stress this enough. And I used to tell people, if you know this, you can answer so many questions right on the step exam. Is that here in this layer, sodium, if activated, the sodium gets reabsorbed, and then you have hydrogen ion and potassium that both get excreted. So when this gets activated, sodium gets reabsorbed, hydrogen gets excreted, potassium gets excreted. That's normal, right? This vesicular layer, you're dealing with cortisol. And then the reticularis, you're dealing with the sex hormones, okay? So normally, this is what happens. Now you have these enzymes, and you just gotta know where to place these guys, right? You gotta know where to place them. We're gonna put 21, we're gonna put 11, and then we're gonna put 17 right there. So now, if you know what normal is, if we can knock out these guys, which is the question that they ask, you gotta understand, when this ACTH comes down this pipe, he gets spread evenly all these. But now let's just say, you knock out the 21, right? Now that's the most common, so they like to ask that question. Say you knock out 21, what happens to all that ACTH? It comes down, but it can no longer go this way. So it all gets pushed here, right? It all gets pushed to the reticularis. So what happens? We get a bunch of this stuff, excess sex hormones. So in 21 hydroxylase deficiency, what does it look like? Well, you get hypotension. And wait a second, what do you mean hypotension? Well, that makes sense, because if it didn't go this way, I'm not reabsorbing any sodium. If I don't reabsorb sodium, my blood pressure is going to go down. Okay, so I get hypotension. And now if I'm if it's an XX, if it's a female, but if the female gets all this excess sex hormone stuff, what's going to happen? She's going to look almost like a guy. So that's when you have that girl enlargement. Okay, and then if it's a boy and they have all these excess hormones, this is where you have that like a precocious puberty. And then of course, if you're not getting the cortisol, you have your salt wasting. Okay, but it makes sense that if you knock these guys out, you're not getting this. You're not getting reabsorption of sodium, and you're not excreting the hydrogen, not excreting the potassium either. But you're not getting the cortisol, but you're getting a bunch of this stuff. That's the most common one. But now let's think about it. What about this? What about what happens when the 17 gets knocked out? Okay, let's go 17 hydroxylase deficiency. Well, let's just see what happens there. If this gets knocked out, where's all the ACTH go? Straight down. It doesn't go over here. It goes straight down because you can't pass that step right there. So what happens if you get a bunch of this? Well, you're gonna get a bunch of sodium reabsorption, right? And so you're gonna have hypertension because of the increased sodium. You're not going to get any androgens, right? You're not getting any of the sex hormones. So if you're the boy, well, you kind of look like you look like a girl. And then if you're the girl, you're just underdeveloped, right? Because it wasn't allowed to go this way. It was knocked out right at the 17. Now the kicker to this whole deal is if you get an 11 deficiency, it looks exactly like the 21. Everything gets pushed this way, except you got a little bit of hypertension. Okay, meaning you got to this point, so you got a little bit of that hypertension. So the 11 hydroxylase looks like 21 hydroxylase, but hypertension. That's the key. You got to have that piece. If I see looks like 21 hydroxylase, but hypertension. That's the key. You gotta have that piece. If I see someone like this, but they have hypertension, you gotta think it's an 11. Okay? So, but hypertension. That's the key. You gotta have that piece. If I see someone like this, but they have hypertension, you gotta think it's an 11.
The boy Neo. Neo, you don't got no pediatrics. Developmental milestones. Come on, Neilman. I love this remix. Where's my he's been slowing down his music drops. He normally drops one literally once a month. He only dropped once this month. 13-month-old boy. I'm so stupid. No, Buterol didn't help him. Could give him epinephrine if it's RSV. Have him placed another right lung. Decrease uptake in REO. No, we should for about illness and get that out of there, get that out of there. Get that out of there. Oh, damn. This one is normal though. It's probably this mess. What is toxic synovitis? I think it has to be toxic synovitis. Cause I don't know what this mess is. You should show that mess on X-ray. Sleepy and not act to herself when she has several lesions on her skin. Not had diarrhea. What is the other thing? The other authentic Sakai. I'm sorry I had this song on repeat, but this message is too good, bro. I can't stop listening to it. And final authentic Sky. So girl, 25% percentile. Fever, vomiting, lesions on the skin. Yeah, she's small. Yeah, she's low blood pressure. Antibiotics. Hey, you gotta give her saline because she's normal. She's not vomiting, so she doesn't need that. need sodium bicarbonate. What the hell is sodium bicarbonate? Do? Let's just try it. Non-chromic hemocytic cells, most likely diagnosis. 4-year-old African American girl with anemia. Wait, it's 6 weeks of being diagnosed with severe hepatitis A. 4 weeks of diagnosis. Looks like plastic anemia. Yeah, that's really plastic anemia. She's down and everything. G6PD now. Sickle cell now. Maybe sickle cell. Thalassemia minor. Following activity is the strongest predisposing factor to patients' positive PPD skin test for tuberculosis. Overseas travel for TB. Yes. Most likely diagnosis. 7-year-old girl with a fall examination 2 days after completing a 10-day course of antibiotics for a second episode of pneumonia in the past year. Also had 2 episodes of otitis media, 1 episode of herpes zoster. Which one is the most likely diagnosis? Sure, HIV. It could be HIV. CGD, no. She probably got HIV from her mom. Most likely pathogen. Previously healthy 8-year-old boy brought to the emergency because of fever, abdominal pain, and bloody diarrhea for 6 hours. So maybe he has like E. coli or something. From the USA or from Mexico. Long examination shows pain and circumvented quadrant mild hepatomegaly. Sigmoidoscopy. Mucosal shows flash-shaped ulcers. I think that's Giardia. Intermeba histolytica. I think that's intermeba. Intermeba histolytica. Giardia. Yeah. Next step in diagnosis, measurement of which of the following. So you have a 2-year-old boy brought to ED. 30 minutes after he fell 8 feet from the backyard. Dang, he dude fell from like the first story, like a second story window, fell 8 feet. Yeah, dude fell. Dude almost fell. It must have been on the, or if it's a 1-story house, maybe he's on top of the house or something. Right side flank tenderness. Except in diagnosis of which of the following. And cranial C. Right side of flank tenderness. I guess you want to see if there's urine and blood. That's the first thing you want to see. Most appropriate intervention to prevent nosocomial transmission. With a girl at hospital, severe cough for 2 days. Episodic staccato-like, often followed by vomiting. 1 week ago, she had rhinorrhea. The mention she appears well without coughing. Few petechiae on the face and thick nasal secretions. So what does she have? So first she just, her nose was running, and then all of a sudden now she's coughing hella, and now she has petechiae on the face and thick. And she has no temperature. She's 4 months old. So what the hell? Contact isolation, vaccination. Pertussis vaccination. Does she have pertussis yet? Can you even give it yet? DTaP? Oh. Yeah, she's 4 months. It could be DTaP. I mean, it could be Bordeaux pertussis. Testicular light cough. Oh, and vomiting. Yes, it's pertussis. Everyone else already has pertussis vaccination. They should. Most appropriate next step in management. 11-year-old girl with spina bifida, but to the physician because I write that pain for 2 days. Oh, it didn't play my Let's go. Let's go, come on. Okay. 11-year-old girl with spina bifida, she has right leg pain, she's paraplegic. Ministers will release. Swelling of the right distal thigh without redness is appropriate next step. Acetaminophen therapy. Range of motion exercises. Can she even do that? She's paraplegic. X-ray lower extremity. Should be X-ray. No fever. Turning her. Might as well. Let me see what's going on. Let's see what's good. And then we'll go acetaminophen. Maybe you go acetaminophen first. Oh, when typically you go NSAIDs. Well, no, you wouldn't go acetaminophen because there's no fever. So yes, I'll go X-ray. Most likely location of the pathology causing this patient's symptoms. 16-year-old girl brought to the physician because she has not had a menstrual period for 4 months. For 4 months, okay. It started at 12. There's normal, which increased hair growth between the breast and chin. Okay. Coarse hair with a chin. So she has PCOS. Location of so what is going on there? The insulin, so much insulin that you creating too much estrogen. So the ovaries to FSH-LH. I think it's ovary. What's the location of pathology causing this patient's symptoms? Where'd you go? Pancreas? Guess where the beta cells are. That's secreting insulin. This is such an annoying question. Because insulin's the big issue. Insulin. It's insulin, so it's pancreas. So I'm going pancreas. And then ovary would be my second choice. Most likely causes patient short stature. Asymptomatic 15-year-old boy. As well, child isolation. He's shortest in his class. He's been 3rd percentile height. Genetic pelvic player. He needs growth hormone deficiency. Either that or constitutional growth delay. No, it has to be growth hormone, bro. Constitutional growth delay. That's second. But I'm going growth hormone deficiency. Most likely inheritance pattern. 5-year-old boy went to the physician because of cleanliness and frequent qualls. In the past 6 months, he did not want to wait till I was 17 years. 17. Larger of the capital. So it's X-linked recessive. It's X-linked recessive. It's X-linked dominant than ET in females. One of the most likely physiologic mechanism for the change in intensity of the patient's murmur. So why did the murmur change in this 1-month-old boy who was just here for a royal child visit? He had a normal pregnancy, 15 minutes of delivery. Of course, he had the soft stroke murmur, that's normal. 40 pulse, normal, respirations 28. Blood pressure is 76 over 54, it's a little low. Well, might be normal. The grade 3 out of 6 hospital measures are best in the middle western border. Falling is most likely a physiological mechanism. Grade 3 out of 6 is holosystolic murmur is heard best in the middle left sternum border. Middle left. Changes in the patient's murmur. Closed as arteriosus. That's a good part of it. Decreased pulmonary vascular resistance. I think it's because the ductus arteriosus is closed. So then it's just the VSD. That's what I'm thinking. Okay, I have to go use the bathroom very badly. Let me do the list of questions. Your analysis shows 4+ protein and no blood, which falling is the most likely diagnosis. So you have a 3-year-old boy. What's the diagnosis in a 3-year-old boy came to the physician because I asked him for 1 week? Let me see. If he went to the doctor, if he got sick like a few days ago, that means it's minimal change disease. Edema, ascites. They don't talk about him getting sick. Cholesterol's high. So it's not minimal change disease. Could be minimal change disease, but he fool ain't got sick recently. That's only for 1 week. If I just focus on multiple pulmonary sclerosis, no, that's like in older people. I guess we're gonna go minimal change disease. I don't know what else will cause MS. X-ray shows perihilar infiltrates. Perihilar. Flying vaccines could have presented this. 2-year-old sickle cell, 2 weeks. So you probably needed to get the freaking pneumococcal vaccine. Paroxysmal cough, like vomiting. What is causing the perihilar infiltrates? I guess you got some kind of. Yeah, I have to use the bathroom so badly. I'm black. Upper GI series, which one is most likely diagnosis? 5-month-old girl got an upper GI series because she has daily episodes of vomiting after feedings. I'm sure you bread. Vomiting is occasionally bilious. Diagnosis of external. So There's no distension, tenderness, or no masses. Just normal rotation. Could be that. Occasional bilious. I'm gonna go pyloric stenosis. It's either GERD. Most likely diagnosis. So you have a 13-year-old girl who's at the physician because she has a 2-week history of mild neck tenderness. She's not had any fever or any changes of weight or nothing crazy like that. It's not even mild neck tenderness. Unless she's serious illness and taking no medicine. Her mother has lupus, so family history of autoimmune disease. Patients at the 50% percentile for iron weight is normal. Pulse 88, normal. Respiration is 18. Normal. Blood pressure normal. Skin texture. No exophthalmos, no simple, no lymphadenopathy. Thyroid gland is diffusely enlarged. No nodules palpated. T3. I don't feel like looking up these values. The anti-peroxidase antibody concentration is 1,000. Her TPO is 1,000. What does thyroid anti-peroxidase do again? She don't have Graves. Hashimoto thyroiditis. She could have thyroiditis. I mean Hashimoto's. Let me look at the NBME step values. Lab values. Let's see what her TSH is. Man. Yo, just give me the PDF, bro. My bad, I should have pressed on that one. What's going on? Yo, just give me the PDF. What are you doing? What is going on? You don't want to show me the freaking... Where's just the picture? What is this ugly mess? TSH 0.5 to 510 is normal. T4 5 to 12 normal. T3 115 to 190. So all her thyroid stuff is normal, but she got this freaking. Why she got this freaking thing? Endemic goiter. It's not thyroiditis because her mug would be like she'd have the hyperthyroid right now. Acute suppurative thyroiditis. Endemic goiter? Why would she get a goiter if she lives in the U.S.? But she has history of autoimmune disease. All her mess is normal. You have to test see the thyroid antiperoxidase antibody. Why is that? I assume that mess is the mess is supposed to be low. Why is it high? What does that do? Thyroid antiperoxidase antibody. Antiperoxidase. Actually, let me just go with the autoimmune disease. I'll just go with Hashimoto. You know, it's supposed to be hyperthyroid and hypothyroid. Ugh. And it's not hot or nothing. Let's go. No. 2-week history. I'm just gonna go. It's thyroiditis A. I don't know what the answer is. What is the cause of these findings in this 14-year-old boy with a cardiac murmur? He becomes easily short of breath. No syncope. Normal vitals. Blowing diastolic murmur at the upper right sternal border. So this is aortic. And it's blowing diastolic murmur. So aortic regurgitation. Why do you have aortic regurgitation? Increased systemic cardiac output, no. Well, yeah, no. Increased systemic vascular resistance, I would say so. Left ventricular pressure overload. What's the machine left ventricular volume overload? Volume overload, I mean, I could see that. Increased systemic vascular resistance. No, it's not the vascular side. The volume overload. Most appropriate next step in evaluation of his poor weight gain. 15-year-old boy with a physician. He's only 15 months old. So last examination 3 months ago, he's at the 25th percentile of length and weight. He's at the 25th percentile for length and weight. So why is he not gaining weight? Para vivir. La 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 la. Yeah, let's calorie count. La la la. 25th percentile. But no, let's not calorie count. We have to figure out what's going on. Why is he freaking so small? I want to test his full stool. Because why is he so small? So that makes me think that he has like freaking cystic fibrosis or something. I want to see if he's even absorbing stuff. Most likely cause of the hypertension. 10-year-old girl brought to the physician because of swelling of the eyelids, feet for 3 days. Okay. Physician because of swelling of the eyelids and feet for 3 days. Decreased urinary frequency. 2 weeks ago she had a sore throat. Yes. It's just like post-strep. Even though minimal changes, he's supposed to be a few days after. This is 2 weeks after. She has autosedema and she has high blood pressure. Gravity, she has a lot of blood. Protein, 3 plus, whatever. So there's a lot of blood in the urine. The cause of the hypertension. Let's see if she has post-strep glomerulonephritis, correct? Stimulation of the parasympathetic system. If post-strep glomerulonephritis, let's see, it's called catecholamine excess. No, idiopathic hypertension, no. Not volume overload. Stimulation of the parasympathetic system. Mineralocorticoid excess, so she is absorbing too much sodium and stuff like that. But why? Idiopathic hypertension. Oh, so she's had the edema, so she has no, so she's absorbing more or whatever. Catecholamine, I want to go. What's an example of a catecholamine? Dopamine, epinephrine, norepinephrine. No, it's not that. Mineralocorticoid is like ADH, aldosterone, things of that nature. Yeah, I'm going Mineralocorticoid excess. So most likely explanation for this patient's failure to pass stool. Most likely explanation for this patient's failure to pass stool. So a 30-year-old girl with Down syndrome not had a bowel movement since birth. Feeds poorly but has not vomited. Has not had any other symptoms. She had Down syndrome. 3 days later, she hasn't had her meconium. Born at term to 39-year-old. Some complicated pregnancy. Rupture remaining 6 hours right to delivery. No meconium staying. You don't feel it. Avogadro 6 and 9. So she has a fever. Blood pressure 90 or 55. If it can't fold, twice a week plus on the iris. She could have Hirschsprung's disease. May have the squirt sign. Duodenal atresia. I know that's supposed to be with double bubble sign. That's with Down syndrome. Actually, yeah, Hirschsprung disease. That's with cystic fibrosis with Hirschsprung's and something else. Duodenal atresia, that may present later. Duodenal atresia. Pancreatic enzyme, no, that's cystic fibrosis. Pancreatic valves of the bowel. This is direct and indirect anticoagulant column system negative. Blood smears not like to show which of the following types of erythrocytes. 3-year-old boy went to the physician because of increased lethargy and jaundice over the past week. So he's 3 years old. And he's tired and has jaundice turning yellow. What's wrong with this little boy? At birth, he had phototherapy for 5 days. That's normal, I guess. His father had a splenectomy at 6 years old. So injection whatever. He's anemic. Total bilirubin, that's 5. Bilirubin. Yeah, bilirubin was this high. Let's splenectomize he jaundice. Does he have like hereditary spherocytosis or something? How fast does that present? He has hereditary spherocytosis. Hereditary spherocytosis. What would that look like? Macrocytic and hyperchromic catastrophe. Coombs test negative. Let's go. I'm gonna go hereditary spherocytosis. I don't remember all the stuff. Most likely cause of newborn's neurologic findings. 1-year-old newborn is jittery and irritable. He's born attempt to a 25-year-old woman. Regular for neurocare, is he missing out on some drugs? Negative for hepatitis B, rubella, HIV, syphilis. He's 10 pounds, he's pink. His posterior function now is very weak, patent. Most likely cause of neurologic findings. Irregular prenatal care. So why would it be adrenal insufficiency? Hypoglycemia, because it is a big baby. Hypoglycemia, that could be why he's jittering. Hypermagnesemia. Underlying cause of these findings. 12 hours after circumcision, 3-year-old boy has persistent bleeding at the circumcision site. On 38 weeks gestation. He was given his vitamin caps and delivery. Right, parietal hematoma. That's normal. He could have been delivered with, because he has a bleeding disorder, and he has oozing blood at the site. Platelets normal. Prothrombin time. I'm gonna go von Willebrand. A little oozing. Let me think. Because normally you say oozing, you think of DIC. Platelet dysfunction. Prothrombin time. Prothrombin time. Prothrombin time 11 to 15 seconds. So that's normal. And PT time 25 to 40. So that's PT time is longer. I forgot. I gotta look up the PT time. PT time. Okay, intrinsic. You do ping pong inside. That's 12, 11. von Willebrand or factor 8 deficiency. Factor 8. Most likely diagnosis 4 hours after an elective cesarean delivery at 38 weeks gestation. This person had an elective C-section, nasopharyngeal tachypnea. In C-section, that can lead you to NERDS. Pneumoconium stadium with preoccupation over O2 set at 88. Lungs are clear though. It'll be this. Most likely mechanism of these findings. 43 weeks gestation, goodness gracious. 3 and 5. Meconium stained. Cyanotic. CO2. CO2 normal. My car 22 28. Where's my CO2? PCL 230, theta 45. So it's metabolic acidosis. Increased peripheral vascular resistance. So it's not meconium aspiration. I think it's decreased pulmonary vascular resistance. Your pulmonary, because he needs oxygen to go in there. There's no surfactant. Okay. Most probably next step in diagnosis. Previously, a 7-year-old girl, because she had a 4-month history of episodes of bright red blood in her stool. Not associated with pain or diarrhea or anything. Growth and development are different for age. Respiration to 18. Hyperpigmentation to the lips and pupil mucosa. What's the thing that causes Pete Jaeger? Do you do colonoscopy? Do you do colonoscopy in a 7-year-old? I don't think you do upper GI. It's bright red blood, so it's not upper GI. It would be lower. So I think you do colonoscopy. But you do but yeah, I think you do colonoscopy. Contrast anemia. But you don't have any pain. Yeah, so contrast anemia, you do that with intussusception. So yes, we go colonoscopy. Go to medical scan. She's 7. And go Meckel. We go Meckel, then colonoscopy after. Most appropriate initial step in management. 16-year-old girl brought to emergency by friends as she passed out. History of substance abuse. She drank Kella. Sclerotictus. What's a step? She knew what she drank. Measurement of blood alcohol concentration. Nebulizer, acetylcysteine therapy, electric ventilation, hemodialysis. What's her respiration rate? Respiration 61, okay. Hemodialysis, no, she don't need to be. Nebulizer, acetylcysteine therapy. So she need to be intubated? No. I don't even know what this nebulized message is. I'll go with that. Most appropriate in determining appropriate management for this patient. So a 15-year-old girl is a patient. She comes to the physician who has a 2-week history of facial rash and fatigue. None the history of stiffness and swelling of her fingers on awakening in the morning. None the history of stiffness and swelling. That's your serious illness. Tired of mild chest pain with these reverberations. She has sickle cell? Primary rash with her cheeks and nose. She has SLE. Tender ulcers on the soft palate. Other erythema tenderness. Do renal biopsy. I don't think anything else will show anything, but renal biopsy, will that show if there's the C3, the I, whatever, that thing? I'm gonna go renal biopsy. I'll select it, dummy. Most appropriate long-term management. 3-year-old girl brought to the physician because of a 2-week history of cough and other condition. Tired and irritable for 6 months. God, like 6 months? Sleeping excessively and snoring loudly. nasal condition will be without my thermal. 1/6 cholesterol in the members on the fourth left. So a mitral, tonsillar adenoid hypertrophy, cardiomegaly, ventricular hypertrophy, pulmonary hypertension, mild tricuspid regurgitation. For a left peristernal space. Long-term management. So it's all these right heart. Does she have tetralogy of flow? Adenoidectomy and tonsillectomy. Oh yeah, I feel like we gotta take this woman's tonsil out. That's good. I mean, that's the main thing right now. Pulmonary vasodilator therapy. That will help reduce her sleepiness and her blood pressure. Tricuspid regurgitation. I mean, if we can't repair tricuspid regurgitation. I feel like we need to do both of these things. This is so annoying. Maybe it'll resolve on its own. Looks like a diagnosis. 10-year-old girl's but the physician got a rash over the eyelids and fingers for 1 week. Violaceous erythema of the upper eyelids and the erythematous atropic alienation of knuckles. Kawasaki. Sclerosis, but does she have any dryness? Weakness of the proximal extremities and trunk. Oh, so she does have some weakness. Looks like a diagnosis. 8-year-old boy puts a physician cut a 2-week history of rash, 1-week history of low-grade fever, mild headache. Small bump on the right thigh, now measures 12 centimeters. So you have an 8-year-old boy. He came to the doctor because he's had a rash for 2 weeks. So it goes for rash, then it went to fever and headache. Roseola does the opposite. Could have Lyme disease. Not that. Juvenile myeloma, no. Atopic dermatitis, no. Herpes simplex, no. Herpes zoster, no. Pedigo, no. Folliculitis, no. Lyme disease. Most likely causal organism. Previously healthy 6-year-old girl's about to emergency because of a severe abdominal pain. So 6-year-old girl, she's at a friend's birthday party. 4 hours after she went to the party, 4 hours later she had to leave because her stomach hurt, nausea, and vomiting. Goodness gracious. Anybody else get sick though? What's in the cake? I mean, I'm just gonna go Staph aureus because that's what I'm always gonna go, but that's some like potato salad and stuff. Beta Juni, that's meat, Clostridium botulinum. That's like in canned foods. That's not like honey. E. coli. No. Shigella, no. All that mess is like meats. Well, Staph aureus. Either Staph aureus or Clostridium botulinum. But if it's Clostridium, no, but then she'd be floppy, so it's not that mess. It is Staph aureus. The most likely immune mechanism of these findings. A 1-month-old girl about to physician because of one-day history of decreased oral intake. Mother says that the child also has blood or her saliva. Born nocturnal following uncomplicated pregnancy and delivery. Inflammation and erythema of the oral cavity with diffuse white puppies that bleed when scraped. Papillary erythematous rash where satellite lesions over the diaper area. One-month-old girl. Blood in her saliva. So that's like Canada. And if you have Canada, it's the T emphasize. Well, I guess it mostly causes patient's weakness. 14-year-old boy is brought to the physician because parents are concerned that he has had several episodes of tripping and incoordination over the past 10 months. This 14-year-old boy, oh Lord, he has high arched feet and hammer toes, high arched feet and a history of distal extremity weakness. Surgery diabetes mellitus severe. High arched feet and a history of distal extremity weakness. Mild weakness of the hand, musculature, and wasting of the anterior tibial and intrinsic foot muscles. Internal reflexes are absent at the ankles. Such vibration. Long distal motor latencies. Goodness, this is so much. It's not diabetic neuropathy. It's not Duchenne. Tooth disease, I don't know what that is. Facioscapulohumeral muscular dystrophy. I don't know what that is. I think it's some kind of demyelinating thing because he has all this. That wouldn't be Duchenne. He has all too many symptoms. Okay, finish that block. Let's finish this I am. Most likely cause 35-year-old man with recurrent episodes of dysuria and pelvic pain over the past 2 years. Dysuria and pelvic pain. He's sexually active. Tender prostate. Most likely cause tender. What's the most common cause of UTI? Oh, urine culture is negative. Chancroid, chancre. Chlamydia trachomatis. Herpes simplex. No. Syphilis. They have syphilis. Vaginalis. What's more likely in this trichomonas? Chlamydia is the one on the urine culture. That's tender prostate. Which one affects prostate? I think chlamydia more. Let's go chlamydia. Because of these findings, the 8-year-old man goes to the physician because of 4 weeks history of moderate numbness and weakness in his left hand. No history of trauma to the hand, hypertension. He takes an allopurinol and type 1 diabetes with insulin. Yes, of course, he has hypertension, like we said. Atrophy of the hypothalamus muscles, middle ring, and small fingers. His weakness in the ambidextrous. Also, these kind of prevent people from being pulled through his fingers. The intrinsic hand muscles are normal. It's just a pinprick is decreased with the palmar aspect. What happened for 4 weeks? What the hell happened to you in these 4 weeks? Nerve root compression. Ulnar nerve compression, and that would make sense. That's always ulnar. What's the next step to determine the cause of the lightheadedness? So, 77-year-old woman goes to a physician because of a 3-week history of lightheadedness. She feels like she's supposed to pass out when she gets out of bed in the morning. Chest pain. She has hypertension, hypothyroidism. She's had the thiazide now with X-ray. She looks tired. 6 feet. Pulse is irregular. Blood pressure is 150 over 90 while supine. She has orthotic hypertension and dry skin, and thyroid is enlarged. So she has hyperthyroidism. Equals. Her TSH is low. Her TSH is supposed to be 0.5, so her TSH is normal. AFib. This is crazy. So she, venous pulsations. You can see her lightheadedness. We know she has AFib. Why are we gonna be monitoring when we know she has AFib? Having kindness and all her muscles. Piece of free thyroxine. I mean, I might as well, yeah. Thyrotropic releasing hormone stimulation test. These patients decrease urine output. 52-year-old woman decrease urine output 6 hours after first. Actually, let me just go finish this peds exam and review this whole thing. Okay, beast. We're gonna review this fast. Okay. How did she get this though? Structural defects in the Purkinje system or may be revealed by alcohol, nicotine, caffeine, or psychological stress. This patient might be filled with an infection or by use of an over-the-counter cough or cold preparation, which may contain pseudoephedrine. Symbiotic drug can be used as a nasal because the symptomatic effects can cause adverse reactions to tachycardia, anxiety, and palpitations. So she had a little cough, and they gave her that, and now they gave her SATSE. So psoriasis can be triggered by removal of scales with complete bleeding after some Gutate psoriasis, what does that look like? plasma type. It does not prove a beautiful foreign body aspiration. Oh, I see. Of course. Same thing as Stranger Similarities. That's so stupid. Leg, calf, purpose. Annoying. Sorta. This kid has meningitis. Wait till I go out. What happened to me? She has substance.
Nigga, I'm the winner, I'm the chosen, I'm much better than these niggas you can fucking whip, man. Black me as your phone, black me as your gram, black me as your life, like, forever. So I don't give a damn, bitch, whatever. So I don't give a damn, bitch, whatever. Said I don't give a damn, bitch, whatever. Life is like a film or whatever. Come and get your film or whatever. Let your heart steal, man. Let the fucking skills keep it coming. Do the fucking dress so I'm better. No more fucking pills, I was better. No more fucking ties, bro, it's broken. I'm a fucking crash, cause it's no lie. Nigga, I'm the winner, I'm the chosen, I'm much better than these niggas you can fucking whip, man. Block me out your phone, block me out your damn, block me out your life, like, forever. So I don't give a damn, bitch, whatever. Said I don't give a damn, bitch, whatever. Said I don't give a damn, bitch, whatever. Said I don't give a damn, bitch, whatever.
How am I supposed to know this patient had freaking meningitis? Fever, hypothermia, lethargy, irritability, which I have. That's beautiful to know. So dumb. Get back pH is 7.3. I don't know. What the heck? Oh, I didn't even see. I should have read. Travel to Ireland. See, I'm so stupid. I should just read the whole thing. Yep, Anthony Basilica has the all sourced. JIDS is pear shaped and nucleated for jelly truffle. I gotta put this in now. Okay. I need to use this charger. Dropper isotidation for Bordella pertussis, bro. Mr. Lecture. So stupid. So stupid. Oh my god. Stupid. Why did I do that? Oh my god. If you don't answer for any other food, just stupid. What the heck? Vomiting. I'm so stupid. I said vomiting. Stupid. He's a small little testament rest for what was pretty much until later childhood. Until she is a princess once I play with another yet. Non-bloody, non-bilious. Trisha versus Public Synosis. Oh my god. I thought that were proxies. I thought that were antibodies. Favorite evaluator of delegation numbers, disease, morphine and Turner syndrome. Oh my god, that's so stupid. Why are we? Here's what I see weight gain. Pray to the Post-stroke glanditis. Hypertension associated with post-trip lymphatics is caused by salt and fluid retention, resulting in volume overload. Oh, why is there fluid retention? Why is there so? Of course, it's hereditary spherophitosis. Increase reticulocyte How is it TTP as long as it's clear, bro? time are you gonna see fluid? It's gonna say the light's clear. It's so annoying. Oh, stage just. About to use the restroom. Use the restroom, take a little break. stir fry. We got the tofu, the jalapeno, the noodles, the spinach. It's nice, some nice vibes. You know what we'll be on. Onion, garlic. Mute myself while I find a lecture to put on.
And the best initial empiric treatment is with vancomycin. We then treat based on the culture. For example, viridins, we treat with ceftriaxone, staph aureus with oxacillin, naphthalene, or cefazolin, fungal with amphotericin and valve replacement, enterococci with ampicillin and gentamicin, and for resistant organisms, we add an aminoglycoside. 144. What is the most accurate test for herpes encephalitis? So for herpes encephalitis, PCR of the CF, this Xanx mirror is not sensitive or specific, and it's actually been discontinued, and serology is useless because 95% of the population is positive anyway. So the most accurate test is PSR of the CSF, more accurate than even a brain biopsy. 145. Neisseria requires what type of isolation? Droplet. Droplet means the close contacts, means the people you have close contact with, not school or work contacts. Only, for example, nurses and medical personnel who were in contact with respiratory secretions. 146. How is syphilis treated? Intramuscular penicillin. Tetradoxycycline if penicillin allergy. Pregnant patients who are penicillin allergy must be desensitized, and for neurosyphilis, IV penicillin. If the patient in that case has a penicillin allergy, we have to desensitize them. By the way, who do you have to notify? The health state department. If the patient has syphilis, you have to report it. 147. How is gonorrhea treated? IM ceftriaxone and oral azithromycin, regardless of whether chlamydia is present. Here's a little bit about gonorrhea. It presents with a greenish-yellow discharge, pelvic and axial pain, and swollen Bartholin glands. Men get a purulent urethral discharge, dysuria, and erythema of the urethral meatus. Disseminated disease requires IV ceftriaxone. 148. What is the treatment for bacterial meningitis in patients 3 months to 60 years of age? Ceftriaxone and steroids. Ceftriaxone can be replaced with cefotaxime, and steroids decrease mortality if it's strep pneumonia. 149. Treatment of flu in patients with symptoms for more than 2 days is symptomatic. After 2 days, they don't do anything. Their neuraminidase inhibitors and Valaxavir are used to shorten the duration of symptoms but do not minimize complications. They are not used after 48 hours unless the patient is hospitalized. 150. A patient has fever, facial pain, discolored nasal discharge. What's the next step? Antibiotics and a decongestion, because we have to be concerned for bacterial sinusitis. All right, let's have some final cardiac questions because they show up so much. 151. An asymptomatic 1-day-old boy has pulse ox in 99% of the right hand, 89% of the right foot. Those still pulses are strong, so it's probably not coarctation. What is the diagnosis? So here we have fetal circulation persistence because blood is not properly being perfused to the lungs. And this allows the PDA, well, this causes that the PDA should have a right to left shunt. So blood is being shunted from the non-oxygenated part, and it's mixing with the oxygenated part and going to the bottom of the body, causing low oxygen saturation. In the hand, it remains elevated 99% because there, it breaks off at the aorta before it gets to the PDA, so it didn't mix yet, and that's why it's 99%, but distal to the PDA, it's low due to the right to left shunt, as we see over here. Question 152. A 2-year-old boy is lucky to deal with fever and respiratory distress after URI, but now he has a cardiac condition. This is viral myocarditis, which shows up after a virus. Acute rheumatic fever would show up after group A strep. 153. A 1-hour boy is evaluated for up after a virus. Acute rheumatic fever is a cardiac condition. This is viral myocarditis, which shows up after a virus. Acute rheumatic fever would show up after group A strep. 153. A 1-hour boy is evaluated for respiratory distress with 95 oxygen on room air. The mother had poorly controlled gestational diabetes. Echo shows a small left ventricular cavity and an increased IV septum thickness. You have to think about hypertrophic cardiomyopathy. Here we want to give beta blocker therapy. So again, for a hypertrophic cardiomyopathy, that could even cause respiratory distress due to the obstruction. Question 154. A 10-hour boy is evaluated in the nursery. Pulse ox 99%. That's good. Baby's trunk is pink. Hands and feet are cyanotic. That's also fine. The low-pitched murmur, 2 to 6 mid-systolic ejection murmur. Heard the upper left sternal border. That's also fine. We're not talking about a ventricular septal defect. That would be lower sternal border. Pulses are symmetric normal. Everything's fine, so reassurance. It's fine. Benign murmurs are often soft, low-pitched, and early mid-systolic. 155. A 1-month-old boy is brought in for a well visit. The baby is breathing well and is not cyanotic. A 3 to 6 hollow stuck murmur and throughout present left lower sternal border. That's a problem because that could be a ventricular septal defect. CXR shows in the large left side of the heart.
What is the pathophysiology of this condition? So we see an enlarged left side of the heart and a ventricular septal defect. That's due to an increase in preload on the left side of the heart, because what happens is blood flows from the left ventricle to the right ventricle, and it increases preload on the left side of the heart, which is the ventricular septal defect. 156, a healthy looking asymptomatic newborn is being evaluated. Blood pressure is 81/53, a 2 to 6 hollow stalk murmur is heard at the left lower sternal border. What is the next best step? So here we see a ventricular septal defect, because that's at the level of the left sternal border, the hollow stalk murmur, but it's soft in intensity, which is a problem because it's probably a big ventricular septal defect. Because soft and quiet, we have to be concerned of a big defect, so we have to get an echocardiogram. Okay. 157, a 5-year-old boy who fainted is evaluated. EKG is shown. What medication should be given? So here we see, I don't know if you can see it so well, but it's prolonged QT syndrome. In prolonged QT syndrome, we give propranolol. All right. Also avoid exacerbating factors. Sotalol and quinidine are contraindicated in long QT syndrome. All right. Question 158. An infant with hemodynamic instability, whether when cardiac surgery now develops tachycardia, tachypnea, distant heart sounds, enlargement of cardiac solet, and CXR. What is the diagnosis? Here we have a pericardial effusion. That's why we have the distant heart sounds. Part of Beck's trial, by the way, distant heart sounds. Question 159. An otherwise healthy looking newborn has cyanosis present on his lips, trunk, and extremities. Oxygen saturation is 75% of room air, as well as after pure oxygen is delivered. No stridor murmurs are heard. What's the diagnosis? So in both of these conditions, oxygen saturation will not improve after pure oxygen is delivered because we have these structural problems. But the difference is that in vascular rings, we would definitely hear a heart sound. We would hear stridor. The patient would present with stridor. 160, baby with poor feeding presents with holosystolic murmur that is loudest at the left lower sternal border. Again, so ventricular septal defect and apical diastolic murmur. What's the diagnosis? Again, ventricular septal defect, diastolic rumble due to increased blood flow across the mitral valve, right? Because as we said before, there's increased preload on the left side of the heart, so there's an increased blood flow across the mitral valve. 161, a 12-year-old boy with a history of polyarthritis and febrile illness now presents with mitral regurgitation on echo. What medication should be given? So he has this mitral regurgitation, polyarthritis, so we want to give penicillin because this is suggestive of rheumatic heart disease, a complicated GAS. Penicillin prophylaxis should be given to prevent recurrence. Also monitor every 6 to 12 months for signs of left ventricular dysfunction. 162, what is the most common congenital heart defect in Down syndrome patients? We said this before, this is ASD. 163, a young patient with chronic back pain, intermittent in Down syndrome patients. We said this before, this is ASD. 163, a young patient with chronic back pain, intermittent bilateral heel pain, impaired spinal ability, limit chest expansion. So this is, of course, ankylosing spondylitis. We see aortic regurgitation in this condition. 164, how does squatting improve cyanosis and ventricular? See aortic regurgitation in this condition. Mm. 164, how does squatting improve cyanosis in tetralogy of Fallot? So it decreases the right to left shunting. Remember, the problem in tetralogy of Fallot is right to left shunting. It's a cyanotic heart condition where we see right to left shunting. So when there's squatting, then it increases the afterload that decreases the right to left shunting to allow a left to right shunting. The afterload that decreases the right to left shunting to allow a left to right shunting. 165, a cyanotic baby has left axis deviation on EKG along with peaked P waves. What is the diagnosis? So this is tricuspid atresia. That's where we see these peaked P waves due to right atrial enlargement in this condition. Remember how tricuspid atresia works. There's no tricuspid valve, so we rely on an atrial septal defect for survival, and the VSD is what allows pulmonary flow, and that explains the holosystolic murmur. Question 166. A newborn has central cyanosis but normal blood pressure in all extremities. A harsh crescendo-decrescendo systolic murmur is heard over the left upper sternal border. What's the diagnosis? So remember, in tetralogy of Fallot, we have pulmonic stenosis, so the murmur represents that. 167, a biphasic stridor in a baby that improves with neck extension represents that. So remember, in tetralogy of Fallot, we have pulmonic stenosis, so the murmur represents that. 167, a biphasic stridor in a baby that improves with neck extension represents this aspiration or airway compression of bivascular ring. Yes, airway compression of bivascular ring. Remember, I said before, there's a stridor, but this stridor improves with neck extension because it relieves the pressure from the vascular ring, as opposed to aspiration of Faramardi. Well, there are two possibilities with that. Either it's in the upper airway, that would cause stridor, but the patient would literally be dying because we see he's choking to death, or in the lower airway, that would not cause stridor. 168, a 20-year-old girl is evaluated for worsening cyanosis and rapid breathing. Pulse ox is 79%, which does not improve with pure oxygen. Again, we have a congenital structural heart defect. We know we have to rely on the PDA, so we have to give prostaglandin E1 to make the baby glad, right? It maintains patency of the PDA. Box 69. Baby born several hours ago presents with cyanosis, tachypnea, normal S1, and a single loud S2. So we have one of the cyanotic heart conditions. Pure oxygen does not improve the cyanosis. What is the defect? So over here, we have transposition of the great arteries. Let's see why it's not the other ones. Well, atrial septal defect, I wouldn't produce cyanosis. Hypoplastic left heart syndrome is actually delayed for a few days. It did not present at birth. And tetralogy of Fallot will produce a harsh sound due to the pulmonic stenosis, as we mentioned before. Now we're going to talk about miscellaneous pediatric questions until the end. Question 170, a 5-year-old girl has pubic hair and facial hair, but no associated symptoms and normal external genitalia. She has no breast buds. So it's not precocious puberty. What's most likely diagnosis? This is premature adrenarche, caused by early activation of adrenal androgens. The patient has no secondary sex characteristics, for example, breasts and testicles. They just have the pubic hair and facial hair. Question 171. An 11-year-old boy has a lateral cystic neck mass anterior to the sternocleidomastoid. So if you see a mass anterior to the sternocleidomastoid, you know it's the branchial cleft cyst. As opposed to the other ones, the dermoid cyst is midline, the cystic hygroma is posterior, it's in the posterior triangle, and it's diagnosed at birth. 172, a 3-year-old girl has vulvar pruritus and fusing of the posterior labia minora. What is the treatment? So estrogen cream if the patient is symptomatic. Usually there are no symptoms and requires no treatment. 173, an 18-month-old girl has febrile UTI. Besides antibiotics, what is required? So for these patients, we get a renal or bladder ultrasound. In these patients, for example, in an 18-month-old girl who has a febrile UTI, we need to check for a defect which may lead to recurrent UTIs. Question 174, which is true of sunlight protection? And the answer is all of the above. We apply sunscreen every 2 hours. Dark clothing protects better than light clothing. UV rays can penetrate clouds, even though they may be mitigated. And SPF 30 to 50 is preferable, not less than 30, and above 50 you don't gain anything. 175, thrombocytopenia, anemia, and splenomegaly are seen in, this is Gaucher disease. Gaucher disease, we also see bone pain and delayed puberty. As opposed to Fanconi anemia, Gaucher disease, we also see bone pain and delayed puberty. As opposed to Fanconi anemia, which we spoke about earlier, hypoplastic thumbs, but no splenomegaly. 176, a 14-year-old girl has no axillary or pubic hair. She has a uterus. What is the next step? So here we want to get an FSH level because the first step in primary amenorrhea is to get an FSH level. For example, it may be due to Turner syndrome. Now, if the FSH is low, we know it's the central cause. We get TSH and prolactin levels, for example, prolactinoma. And if it's high, we get the karyotype, as I mentioned before. If FSH is high, it may be due to Turner syndrome. 177. And a 13-year-old girl presents with a worsening headache over the last 24 hours with nausea and vomiting. The headache is in the right frontal area and is pulsatile. Similar headaches have occurred monthly. And what's the best diagnostic step? So we got no testing because this is likely just a migraine. Diagnosis is clinical. And we treat this as NSAIDs, and if it's refractory with triptan. 178, a 7-month-old baby with a history of abdominal surgery soon after birth presents with chronic symptoms of episodic bilious vomiting, abdominal pain, irritability, and inconsolability. Bowel sounds are normal, stool is negative for blood. What's the most likely diagnosis? So if you have the 7-month-old baby, it's not pyloric stenosis that will present earlier. This is intestinal malrotation of volvulus, which, as we mentioned before, can present in the first month, but could present up to a year. Question 179. The 11-month-old girl has bright red stools since yesterday. P shows diffuse abdominal tenderness. Fecal testing is positive for blood. What is the diagnosis? It's very likely to be intussusception. That's what's going on over here. Intussusception. That's why she's positive for blood. Question 180. A 4-year-old boy has watery diarrhea for 2 days. It becomes bloody. So watery diarrhea becomes bloody. No temperature. The abdomen is diffusely tenderned out. Rebound. What's the diagnosis? So here we have infection with E. coli. Remember, E. coli causes watery diarrhea. That becomes bloody. Caused by Shiga toxin, and patients are afebrile or have a low-grade fever. It self-resolves within a week, but infection may be complicated by HUS, especially after 1 to 2 weeks, and that's why you should definitely not give antibiotics to these patients. Question 181, the most common bug isolated from pseudomonas cultures of CF patients is Staph aureus. Again, we're talking about pediatric patients. Pseudomonas aeruginosa is seen in adults. 182, a 12-year-old girl's upper and lower extremity swelling without itching or redness. This happened in the past and the episode self-resolves after 3 days. What's the next step? So we want to get the C4 levels because we're talking about hereditary angioedema. It's diagnosed through C4 levels. 183, a 19-month baby is evaluated for past and seen in adults. 182, a 12-year-old girl's upper and lower extremity swelling without itching or redness. This happened in the past and the episode self-resolves after 3 days. What's the next step? So we want to get the C4 levels because we're talking about hereditary angioedema. It's diagnosed through C4 levels. 183, a 19-month baby is evaluated for feeding dysfunction due to dysphagia. He has had poor weight gain. He also has a history of eczema. How is this condition diagnosed? So here we want to get an esophageal biopsy because we're talking about esophageal esophagitis. where lots of eosinophils on histology, and that's diagnostic. First-line treatment would be avoid the dietary triggers that leads to the esophagitis. A 5-year-old boy comes in for his well visit. What is indicated at this well visit for a 5-year-old boy? So we want to get autism screening because that's up until 2, and we want to check for vision testing because that's checked in screening because that's up until 2, and we want to check for vision testing because that's checked at every single visit. Rotavirus at age 2 to 8 months, meningococcal vaccine at age 11 or 12, and then at 16, or in patients at 2 who are at high risk, such as a spleen or HIV. 185, a 3-year-old boy who recovered a week ago from URI now has unilateral neck swelling, which is red and painful. He also has fever. What's the treatment? So we want to give clindamycin because we want to get, this is for the acute cervical lymphadenitis, which is common in children below the age of 5. Question 186, Burkholderia cervical lymphadenitis, which is common in children below the age of 5. Question 186, Burkholderia capacious infection and granulomas on biopsy are seen in CGD, chronic granulomatous disease, where we see catalase-positive organisms. It's due to defect in NADPH oxidase. 187, apnea of prematurity is treated with caffeine. You give them the soda. No, I'm just kidding. You don't give them the soda. You give them caffeine, like 10 milligrams. Question 188, irregular. You give them the soda. No, I'm just kidding. You don't give them the soda. You give them caffeine, like 10 milligrams. Question 188, irregular patchy hair loss with areas of uneven hair, even by the eyebrows. So this is trichomania. In alopecia areata, we see patches are circular, they're smooth, they're completely devoid of hair. As opposed to over here, where we see uneven hair. And traction alopecia is from prolonged tension. We're not going to see that, for example, in the eyebrows. 189, perianal strep dermatitis is managed with penicillin, because it's caused by strep, right? That's why it's called strep dermatitis. 190, an 11-year-old girl has anxiety, tachycardia, and diaphoresis. She has elevated urinary catecholamines, but workup for FeO is negative. What should we check next? We want to check for mercury. Mercury can present like a FeO, but it's not. 191, lack of response to positive affirmation in child with a history of abuse. This is reactive attachment. They don't want love, and they're not very good at eye contact and physical touch. They avoid it. 192, fetal distal phalange hypoplasia, along with cleft lip and palate, along with, I'm not sure why I wrote it like this, microcephaly, is seen in which toxicity? This is seen in phenytoin. Again, the phalange hypoplasia is in phenytoin. Opposed to lisinopril, that leads to oligojamnios and Potter sequence, and cocaine with abruptio placentae and growth restriction. A 3-year-old boy has a choking episode, developed wheezing, which improved with nebulized albuterol, and CXR was negative, but the cough persists a few days later, so he choked, he probably aspirated. The patient has no fever or congestion, and CXR is still negative. What's the next steps? We want to get a bronchoscopy for the aspiration. 194, a 9-year-old boy developed sudden onset right-eyed redness and hearing. The right globe is bigger, but extraocular movements are intact. Who is at risk for this condition? So this is glaucoma, Sturge-Weber patients. A lot of them, 50% of them get glaucoma. We diagnose with tonometry, and the treatment is surgery to preserve vision. 195, 12-year-old girl has poor growth, puberty delay, and worsening headaches with papilledema. This is due to suprasellar mass. These are associations with the craniopharyngioma, where we see pituitary stalk compression. She has poor growth because of the reduced GH. Question 196, which vaccine is given at 2 months? All of these are given at 2 months. Hep B, rotavirus, DTaP, Haemophilus influenza type B, and PCV, and polio, as you can see in the chart over here. Remember, preterm infants should receive routine immunizations according to their chronological age, not the corrected age for gestation. 197, fetal growth restriction refers to, both are true, fetal weight less than 10% and birth weight less than 3rd percentile. There's a differentiation between symmetric, due to congenital condition, and asymmetric fetal growth restriction. So an asymmetric, that would be due to, for example, uteroplacental insufficiency. 198, a child undergoes anaphylactic shock. What are the values of CO, CVR, PCPW in this condition? So an anaphylactic shock, so they have decreased cardiac output, and that's because they have decreased venous return, because everything's just dilated everywhere. And that's why they have a decreased SVR, because everything's just dilated. And of course, if all these things are dilated and everything's dilated, it leads to a decrease in PCPW because there's no pressure backing up against it. And here we see a chart over here, anaphylactic shock, everything is going to be decreased. Well, I guess heart rate is going to be increased, but all these values that we mentioned are going to be decreased. 199, a 13-year-old girl comes to ED in severe respiratory distress. She has a history of seasonal allergies and intermittent cough. P reveals wheezes, chest tightness, and cough. What is the treatment? So here we need to give inhaled bronchodilator because here she has an asthma exacerbation. That's why she has seasonal allergies, is likely an asthma exacerbation, so we give an inhaled bronchodilator. Also give, again, albuterol, ipratropium bromide, and systemic corticosteroids. 200 post-exposure prophylaxis for varicella in an otherwise healthy 1-year-old is the vaccine. As long as they're 1 or above, they get the vaccine. they get immunoglobulin if they're that age or older, if they're immunocompromised, but if they're immunocompetent, we give them a vaccine. Also, if a baby comes out of mommy and mommy has varicella, as long as she was diagnosed 5 days before or 2 days after delivery, we give post-exposure prophylaxis of immunoglobulin to the baby. 201, a 5-month-old girl has signs of hydrocephalus, fussiness of immunoglobulin to the baby. 201, a 5-month-old girl has signs of hydrocephalus, fussiness, full fontanelle, and large head. What is the next step? We want to get an MRI or an ultrasound to see what's going on inside. Lumbar puncture is not routinely done to diagnose hydrocephalus. 202, a positive squirt sign, Hirschsprung, right? 203, a 5-year-old boy to a mother with grave disease, his low birth weight, warm tachycardia. What is the cause? This is transplantantal TSH receptor antibody. We want to give these patients methimazole and a Ablea-Blocker to symptomatic babies until it self-resolves after a few months. 204, in splenic and Ablea-Blocker to symptomatic babies until it self-resolves after a few months. 204, in splenic sequestration crisis, reticulocytes are elevated as opposed to in aplastic anemia parvovirus B19 where there's reduced reticulocytes. 204, opposed to in aplastic anemia parvovirus B19 where there's reduced reticulocytes. 205, volume overload, where there's hypertension, edema in an 8-year-old boy with acute post-strep cholangitis managed with, we give them furosemide to manage the hypertension. Zoprenil is not routinely given in AKI because of concern for exacerbated hyperkalemia. 206, a 6-year-old boy has anal pruritus after swimming in a lake earlier. Inspection shows erythema with coloration, no fissures. What is the treatment? So we give them pyrimethamine, pamoate, or albendazole. We also treat household members because it's contagious. This is Enterobius vermicularis. 207, a newborn has cyanosis with feeding that is relieved by crying. How is this condition diagnosed? So over here, we're dealing with a tracer. 207, this newborn has cyanosis with feeding that is relieved by crying. How is this diagnosed? Failure to pass the catheter through the nares, because here we're dealing with choanal atresia. It could be unilateral or bilateral. We diagnose it with CT or endoscopy, and we treat it with surgical repair. Again, feeding that is relieved by crying. This may be part of Charge syndrome, where we see these other conditions: heart disease, atresia of the choana, retarded growth, CNS abnormalities, genital abnormalities, and ear abnormalities. 208, a 4-day-old lethargic infant presents with a half-hour history of jerking movements of his limbs, so it's seizures. He has been vomiting after feeding. The liver is palpable and jaundice. What is the diagnosis over here? So here, this is galactose 1-phosphate uridyl transferase deficiency. This is galactosemia. They cannot produce glucose from their galactose. Galactosemia. Here, this is galactose 1-phosphate uridyl transferase deficiency. This is galactosemia. They cannot produce glucose from their galactose, and therefore they present with these symptoms, and that's why galactosemia is the contraindication to breastfeeding. 209, a 6-month-old is brought to the pediatrician for the first time. The doctor noticed that the left hemiscrotum is empty while the right has palpable round mass is palpated and the cannot be brought down. So he's 6 months old. What's the next step? Surgery, because it's at 6 months. At that time we say it's time for surgery. 210, a 10-year-old boy is brought to the ED for 3 days of fever, abdominal pain, headaches, and after overnight near a lake. Symptoms have been worsening. Platelets are 46,000, really low. Aminotransferases are elevated, and there's an macular rash now in the arms and legs. What's the next step? So we have to give doxycycline for Rocky Mountain spotted fever. 211, pulmonary veins drain. What's the next step? So 46,000, really low. Aminotransferases are elevated, and there's a macular rash now in the arms and legs. What's the next step? So we have to give doxycycline for Rocky Mountain spotted fever. 211, pulmonary veins drain into the SVC. What is the diagnosis? So of course the pulmonary veins should drain into the left atrium, the left side of the heart. If they're draining into the SVC, that's a big problem. That's anomalous pulmonary venous return. It could be either partial or complete. So the pulmonary vein drains into the SVC or into the right side of the heart, the right ventricle or the right atrium. And we look for in regular IVC O2 saturation, for example, of 65%. Of course, the inferior vena cava is going to be low. But if we then take a look at the right side of the heart, and the right side of the heart has an high O2 saturation, such as 86%, 90%, we know that it's coming from the lungs, and that's a big problem. And therefore, of course, we have to treat it with surgery. 212, newborns with myelomeningocele most likely have Chiari-2 malformations. You know that in 95% of cases of myelomeningocele, the patient has Chiari-2 malformation, where there is this downward displacement of the cerebellum, the brainstem, and the fourth ventricle. 213, recurrent ear infection in a child, unilateral hearing loss, and scarring on the tympanic membrane. This is cholestoma. It leads to cranial nerve palsies and brain abscesses. We have to treat it with surgery. 214, a 4-year-old boy is not walking due to hip pain and a low-grade fever. What is the initial step to distinguish between transient synovitis from septic arthritis? For example, where the diagnosis is unclear, we have to get a bilateral hip ultrasound because, for example, in septic arthritis, it's unilateral. It's always unilateral. In transient synovitis, it may be bilateral. If it's unilateral, we have to do further workup for septic arthritis, so we get an arthrocentesis to assess for that condition. for that condition. Question 220, what is benefit of circumcision? Well, all of these. It reduces UTI in the first year, cancer, STI, and balanitis. 221, which molecule crosses the placenta? IgA and IgM do not, that's IgG. Rather, creatinine does, and that's why if a baby has a high creatinine level at birth, but the mommy has renal failure, you don't need to be concerned because the baby's levels will normalize in a few weeks. It's just that creatinine across the placenta. 222, this should be. A 6-month blood has so a 6-month-old has blood on the outside of his hard stool a few weeks after starting solid, so this is probably not such a big problem. It's probably just the fact that the solid's causing constipation. That's why the blood on the outside of the stool probably causing an anal fissure. So the next step would be to add fiber, such as pureed prune, or apply apple juice, apple juice to the diet. 222. How many doses of HPV vaccines does a 13-year-old girl need to get? She only needs 2. If she's less than 15, she only needs 2. 223. Do full-term infants need iron supplements in the first 4 months of life? No, they have enough iron reserves. Only preterm babies need iron supplements up to 1 year. All breastfed babies should get vitamin D supplementation. 24. What is the diagnosis over here? This is seborrheic dermatitis. It shows up not only in adults, adolescents and adults, it'll also show up in babies, and we treat it with emollients if there's no response, topical antifungals, and we may need to apply low-potency corticosteroids. 225. 5-year-old boy with a history of bedwetting and UTIs has fatigue, blood pressure 131/82, which is high for a kid, and protein 2+ on your analysis. What's the next step? So here we want to check the creatinine. Because he's bedwetting and use UTIs, high blood pressure, it could be concerned for a kidney dysfunction. We all need to get renal imaging, ultrasound, and avoiding cystourethrogram. 226. A 2-year-old boy has history of a card infection, absent lymphoid tissue. What's the next step? We want to get flow cytometry for X-linked globulinemia. What's absent lymphoid tissue? What's the next step? We want to get flow cystourethrogram. 226. A 2-year-old boy has history of a card infection, absent lymphoid tissue. What's the next step? We want to get flow cytometry for X-linked globulinemia. 227. What's the treatment for this newborn? Reassurance is just a hepatohematoma. It resolves by 1 month of age. 228. What's the treatment for neonatal sepsis? Ampicillin, gentamicin. We may want to get acyclovir for herpes encephalitis. All right. As I said over here, gentamicin for E. coli, ampicillin for GPS and listeria, and acyclovir for HSV. We want to get cultural CSF analysis and urinalysis first before we give the antibiotics to get this specific bug. 229. A 2-year-old has Gower sign. What's the next step? We want to get a CK level. We mentioned this already. Right. 230. What's the first step in evaluation of a 16-year-old patient with signs of meningococcal meningitis? We want to get a lumbar puncture to check the CSF values. We get a CT scan without contrast only if there's a recent seizure, immunocompromised papilledema, or focal neurologic deficits. Otherwise, we want to get the lumbar puncture first in Neisseria meningitis. 231. What is the treatment for neonatal clavicle fracture? Reassurance. It's just going to resolve. We also do gentle handling. Splint figure 8 is an older child with a non-displaced clavicle fracture, and surgery in an older child with a displaced clavicular fracture. 232, an unvaccinated 3-year-old boy has respiratory stress in a tripodiclavicular fracture. Tooth fracture and surgery in an older child with a displaced condition. What is the treatment after intubation? Ceftriaxone and vancomycin. For ceftriaxone for strep and H flu, and vancomycin for MRSA. 232, a 13-month-old boy has recurrent non-periodic infections of neutrophilia. What is the associated finding with this condition? So again, this is leukocyte adhesion deficiency, delayed umbilical cord separation, where we see reduced CD18. Neutrophils can't travel to the affected site. That's why there's no pus in the infections. 234, several purple found in the legs of an 8-year-old girl who is also complaining of hip, joint, and abdominal pain. What is required for diagnosis? Nothing else is required. This is Henoch-Schönlein purpura. As long as we have the palpable purpura, the joint and abdominal pain, we make a diagnosis, the clinical diagnosis, this condition, Henoch-Schönlein. 235, a 4-year-old girl has fever, dysphagia, muffled voice, and pain with neck extension, but no stridor or rhonchi. Lateral x-ray is shown. What's the diagnosis? Is a retropharyngeal abscess. Epiglottitis would show drooling stridor in the thumbprint sign. Question 236, patients with constitutional growth delay, do they reach or not reach normal adult height? And they do. They do reach normal adult height. Just take some time. 237, a 7-year-old boy who's otherwise healthy has acute abdominal pain, vomiting, and elevated amylase and lipase. What's the cause? So he has a biliary cyst causing pancreatitis. All right, we have to surgically remove the biliary cyst. 238, besides deferral of circumcision, what management is indicated for a newborn with severe hyposphagia? We have to get karyotype analysis and pelvic ultrasound. The reason is because it's associated with virilization, mosaicism, and other sex abnormalities. All right, 239, a 1-month-old infant has painless bloody stools. Weight is normal, P is normal. What is involved in the pathogenesis of the painless bloody stool? This is the eosinophilic inflammation of the distal colon and rectum. This is food protein-induced allergic proctitis occurs in babies less than 6 months, and we have to change the baby's diet. 240, a 10-year-old boy has mucosal neuromas and marfanoid hepatitis. What is he at risk for? So, a medullary thyroid cancer. Here, the symptoms are associated with men too. The neuromas and the marfanoid hepatitis. 241, a 6-year-old boy travels around the world with his father. He now has 2 weeks of diarrhea with blood seen in it over the last 6 days. What's the most likely cause? The most likely cause is Endomyia histolytica. E. coli would not, the traveler's diarrhea form would produce a watery diarrhea, and that resolves in less than a week. 242, a 15-year-old male has gradually worsening hearing in both ears and hypertension. Kidney function is declining. His mother's father also had a similar condition. This sounds like Alport syndrome. Kidney and ears. Urinalysis will show red blood cell test because of glomerulonephritis, the red blood cells in the urine. It's an X-linked condition, and that's why it shows up in the boys. 243, a 3-year-old girl has acute onset edema with low albumin, hyperlipidemia, and proteinuria. What is the most likely diagnosis and treatment? So if a kid has a nephrotic syndrome, it's most likely due to minimal change disease, common childhood nephrotic syndrome, and we treat it with steroids. 244, a 4-year-old boy now has a low-grade fever and a bloody mucousy diarrhea. What should be done? Supportive care. We don't want to give antibiotics because it can instigate an HUS. 245, management of genu varum and otherwise healthy. Give antibiotics because it can instigate an HUS. 245, management of genu varum and otherwise healthy 18-month-old baby is reassurance because little kids are allowed to have bowed legs. We're not worried about a vitamin D deficiency because normal for kids up to 2 years of age to have bowed legs. We're not worried about the vitamin D deficiency until later on. 246, what is first-line treatment for a 12-year-old girl with OCD? So an OCD patient, we don't give psychodynamic therapy, we'd give CBT. It's an SSRI. So again, the first-line treatment for a kid with OCD is either SSRI or CBT, cognitive behavioral therapy, not psychodynamic therapy. Right? 247, when is it recommended that a persistent congenital umbilical hernia be surgically treated? At age 5. So again, descend testicle by age 6 months, but the hernia by age 5. But it usually spontaneously reduces by then. 248, what is shown in X-ray? We saw something similar to this before. This is necrotizing enterocolitis, and we give empiric antibiotics right away to avoid septic shock and surgery if there's perforation. Question 249, 248, what is shown in X-ray? But the hernia by age 5. Treated at age 5. 247, when is it recommended that a persistent congenital umbilical hernia be surgically treated? At age 5. So again, descend testicle by age 6 months, but the hernia by age 5. But it usually spontaneously reduces by then. 248, what is shown in X-ray? We saw something similar to this before. This is necrotizing enterocolitis, and we give empiric antibiotics right away to avoid septic shock and surgery if there's perforation. Question 249, 1-week-old baby has vomiting, dehydration to avoid septic septic shock, and surgery if there's perforation. Question 249. 1-week-old baby has vomiting, dehydration, poor feeding, elevated potassium to BUN, and low sodium. What value will be elevated? So these symptoms point to 17-hydroxyprogesterone elevation due to the 21-hydroxylase deficiency. What happens is there are decreased aldosterone levels that leads to dehydration and salt wasting. The salt is going into the urine and water is following. There are going to be decreased cortisol levels due to the deficient enzyme, and that leads to hypoglycemia. Now, whereas there is virilization in females, in males they have normal genitalia. They may have an enlarged penis. 250. What is the first line management of patient with precocious puberty? We want to get bone age evaluation to assess bone maturation. If it's advanced, it may be due to an underlying pathology such as an endocrine abnormality. Alright, so that's the end of this video over here. I know it went really fast. I hope you gained something from it. Stay tuned for more. Alright, welcome to our complete pediatrics. How many months? At 6 months. Remember the rules of threes. Alright, welcome to our complete cardio review for the USMLE Step 2. In this video, we're going to have 200 cardiology review questions, and we're going to be covering everything you need to know for cardiology, and yes, you will be prepared on exam day. Stay tuned, as in the next several videos, we're going to be covering all topics for the USMLE Step 2. Upon completion of this series, a review packet will be available at my website, agmonix.com, and of course, if you haven't done so already, please subscribe to this channel. So let's begin. Question number 1. A 37-year-old woman has left-sided chest pain that worsens with movement of the left arm. Palpation of the chest reproduces the pain, and the EKG is shown. What is the next best step? Pacemaker or observation? Well, this question is actually pretty easy, because it says that palpation of the chest reproduces the pain, and therefore we know, at least for the purposes of exams, that this has nothing to do with ischemia. This has nothing to do with the heart. This pain over here is actually musculoskeletal in origin. She likely has just muscle pain. That's why palpation of the chest would reproduce the pain. In ischemia, palpation would not reproduce the pain. As far as the EKG, we see a normal EKG, except for an incidental finding of a prolonged PR interval. This would be consistent with first-degree AV block, which is generally asymptomatic. So that's what we have over here, a lady with musculoskeletal pain with an incidental finding of a first-degree AV block on EKG. And this is the point, that ischemia produces a sore, squeezing, or pressure-like pain that does not change with movement, palpation, or respiration. And in fact, ischemia can effectively be ruled out if there is pain with movement, or pain with palpation, or pain with respiration, at least for the purposes of the USMLE. Question number 2. Oh, we have a fun mnemonic coming up for this one, as you'll see. Here's the question. A 52-year-old woman recently started on a blood pressure medication, now complains of chest tightness, pain in her elbows and knees, and erythematous plaques on her face, arms, and torso. Which medication caused this to occur? Lisinopril, furosemide, hydralazine, or verapamil? So here, we're dealing with drug-induced lupus. That's why she has pain in her elbows and knees and erythematous plaques on her face, arms, and torso. Which medication causes drug-induced lupus? Hydralazine. Besides flushing and headaches, hydralazine can cause drug-induced lupus. Lisinopril, furosemide, and verapamil have their own side effects, but they are not generally associated with drug-induced lupus. Here we have a fun mnemonic for the drugs that cause drug-induced lupus. The mnemonic is SHIP. S for sulfasalazine, H for hydralazine, I for isoniazid, P for procainamide, and P for penicillamine. And I put these loops over here around the anchor to help us remember lupus. These are the drugs that cause drug-induced lupus, the SHIP drugs. Question number 3. A 61-year-old woman with a history of chest pain presents with 10 minutes of crushing substernal chest pain radiating to the left arm. Troponin T levels are 0.4. What is the diagnosis? Stable angina, Prinzmetal's angina, unstable angina, or MI? This is easy. Troponin T levels are elevated at 0.4. This is what separates MI from unstable angina. That in MI, the troponin T levels will be elevated above 0.4. We just take a look at the other choices over here. Stable angina is when there's chest pain reproducible with exertion, such as exercise. In Prinzmetal's angina, there's a vasospasm of the arteries, but of course there will be no cardiac enzymes, and treatment is with calcium channel blockers. And in unstable angina, there are no cardiac enzymes, and treatment is similar to MI. So the answer over here is myocardial infarction, because we have elevation of troponin levels above, or at least at, 0.4. Question number 4. A 50-year-old woman recently started taking fluconazole and ondansetron. She now developed palpitations, and this is her EKG. What is the proper treatment? Well, in the EKG, we see torsade de pointe. What is the treatment for that? Magnesium. Intravenous magnesium is first-line therapy for stable patients with torsade de pointe. And cardioversion is indicated if the patient is hemodynamically unstable. And here we just have a fun mnemonic for the causes of torsade de pointe. Antiarrhythmics, antibiotics, antipsychotics, spelled with a C, antidepressants, antiemetics, and antifungals. And of course, various electrolyte abnormalities such as decreased magnesium, potassium, or calcium. And symptoms of torsade de pointe include palpitations, dizziness, and syncope, which are typical, and it could even present with sudden cardiac death, and that's why we want to treat it. Question number 5. A man comes to the ED with crushing chest pain for the last hour. EKG shows ST elevations in V2 through V4, and apparently the guy doesn't even have a face. No, I'm just kidding. That's just my picture over here in the cartoon. But anyway, we're dealing with an anterior wall myocardial infarction. So what's the next step? CCAM B level, oxygen, thrombolytics, or aspirin? And the answer is aspirin. We want to give aspirin as soon as possible because we're dealing with an MI. It's critical to give aspirin as soon as possible since it lowers mortality. CCAM B level, well, those levels won't be elevated until after an hour. Oxygen, that doesn't lower mortality. And thrombolytics, yes, but only after 2 antiplatelets, aspirin, and a second antiplatelet, such as clopidogrel. Here we just have a nice summary of the time frame of diagnostic test abnormalities. For MI, EKG, that will be abnormal immediately. The myoglobin will be elevated after about 1 hour and will continue for 2 days. CKMB, that will be elevated after 5 hours and will continue for 2 days. And troponin levels will be elevated after 4 hours and will continue for 10 days. Now, because troponin levels will be elevated for up to 10 days, it can't distinguish a reinfarction occurring several days after the first event. That's why CKMB level is better for reinfarction, since it should be gone after about 2 days. Question number 6. A 62-year-old woman with hypertension comes to the ED with several days of chest pain and shortness of breath. Now she is unresponsive and the EKG is shown where we see ventricular fibrillation. What is the next step? Defibrillation, cardioversion, amiodarone, magnesium sulfate, or epinephrine. So here we're dealing with ventricular fibrillation, and therefore we do defibrillation, not cardioversion. Cardioversion is, for example, in a hemodynamically unstable patient with tachyarrhythmias. But for ventricular fibrillation, we have to do defibrillation. Cardioversion would induce a stimulation to the QRS complex, but in ventricular fibrillation, where you don't have a QRS complex, we can't do cardioversion. We have to do defibrillation, and you can look at the other choices for what they would be used for. Question number 7. A 26-year-old athlete comes into the office for a routine checkup. EKG shows sinus bradycardia, progressive lengthening of the PR interval, followed by intermittent drop QRS complexes. So here, we're dealing with a Mobitz type 1 second-degree AV block, and no ST segment abnormalities are present. So what's the next step? So basically, we're asking, what do you do in Mobitz type 1 second-degree AV block, pacemaker, or reassurance? And the answer is reassurance. Just like type 1 AV block, Mobitz type 1 second-degree AV block is usually asymptomatic. So first degree is asymptomatic, second degree is usually asymptomatic, second degree by type 2 presents usually with fatigue, lightheadedness, and syncope, and requires a pacemaker generally, and third degree involves fatigue, lightheadedness, syncope, and of course requires a pacemaker. Question number 8. A 46-year-old man has had frequent epigastric burning after playing basketball for the past 6 months. Antacids provide no relief. Blood pressure is 142/91. There are no heart murmurs, and the abdomen is non-tender. The EKG is normal. What's the next step? Exercise EKG or H. pylori stool testing. So here we're dealing with a cardiac problem, and therefore exercise EKG. And the take home over here is get an exercise stress EKG in patients with suspected stable ischemic heart disease. This brings us to our next point, angina classification, typical angina versus atypical angina. In typical or classic angina, there's substernal chest pain or discomfort that is provoked by exertion or emotional stress and relieved by rest or nitroglycerin or both. And in atypical angina, that applies when 2 out of the 3 criteria are met, such as in our example where the guy had epigastric pain instead of substernal chest pain. Question number 9. A 51-year-old woman with a history of hypertension comes to the ED with chest pain and diaphoresis that is less than 24 hours. EKG shows ST elevations in 2, 3, and AVF. So we're dealing with an inferior wall MI. 3 days days later, she developed sudden shortness of breath and low blood pressure. So something happened. And her body basilar crackles and a faint systolic murmur. What is the cause of the patient's new symptoms? Papillary muscle rupture or left ventricle free wall rupture. This presentation is most consistent with mitral regurgitation secondary to papillary muscle rupture. That's why there's a faint systolic murmur that represents the mitral regurgitation, the acute mitral regurgitation. The bibasilar crackles represent blood being backed up into the lungs. So again, we're dealing with papillary muscle rupture leading to mitral regurgitation. We take a look at this chart over here, we see the time frame of dealing with mitral regurgitation. To papillary muscle left ventricle free wall rupture. This presentation is most consistent with mitral regurgitation secondary to papillary muscle rupture. That's why there's a faint systolic murmur that represents the mitral regurgitation, the acute mitral regurgitation. The bibasilar crackles represent blood being backed up into the lungs. So again, we're dealing with papillary muscle rupture leading to mitral regurgitation. We take a look at this chart over here, we see the time frame of the various post-MI complications. We see papillary muscle rupture occurs acutely or within 3 to 5 days, whereas free wall rupture occurs within 5 days or up to 2 weeks. So the time frame is not really going to give it away. What's going to give it away is the presentation. Now, if we look at the coronary artery involved, in papillary muscle rupture, that involves the RCA, whereas in free wall rupture, it involves the LAD. So in our situation, where we're dealing with an inferior wall myocardial infarction, that generally involves the RCA. That also gives it away. Now, just a little mnemonic over here is that Papa likes RCA computers. Papa for papillary and RCA computers for right coronary artery. That the right coronary artery is one involved in papillary muscle rupture, whereas free the LAD, this reminds us that the LAD is involved in free wall rupture post-MI complications due after a myocardial infarction. Question number 10. A 53-year-old woman is evaluated 5 days after an MI involving the LAD. So again, LAD, that reminds us, free the LAD, free wall rupture. Let's see if we get this right. She suddenly develops chest pain and EKG shows heart rate of 140 a minute. She soon becomes unresponsive. What is the diagnosis? So again, LAD, free wall rupture, and this sudden onset decompensation is consistent with free wall rupture. In IV septum rupture, it's unlikely to cause such a rapid progression to pulselessness. Question 11. What is the pathophysiology of an S4 sound? ATP depletion or increased elasticity? And the answer is ATP depletion. And the explanation is like this. Myocardial relaxation, i.e. diastole, is an ATP-dependent process. Therefore, ischemia of the myocardium would cause the left ventricular walls to become stiff and unable to relax. Therefore, during atrial contraction, blood strikes against the stiffened left ventricular wall and creates the fourth heart sound. We just have a chart of features of S4 and S3. Again, S4 is caused by blood hitting a stiff left ventricular wall during atrial contraction, whereas S3 is caused by blood filling an enlarged left ventricular cavity during passive diastolic filling. Question 12. The most common cause of isolated aortic stenosis in elderly patients is, so why do elderly patients get aortic stenosis? Age-related calcific changes. Question 13. A 1-hour-old baby is evaluated for respiratory distress with 95% oxygen on room air. The mother had poorly controlled gestational diabetes. Echo shows a small left ventricular cavity and increased IV septum thickness. What is the next best step? Beta blocker or surgery? So here we're dealing with hypertrophic cardiomyopathy of infancy, and that's beta blocker therapy. We give beta blockers in order to treat the hypertrophic cardiomyopathy. This is a potential neonatal complication of maternal diabetes, usually when it's poorly controlled, and it's caused by increased glycogen and fat deposition in myocardial cells, and we give beta blocker therapy. Normally, this actually self-resolves within a year, but in the meantime, we give beta blocker therapy. Question 14. A 54-year-old woman with a recent URI comes in with worsening exertional dyspnea over several days, low blood pressure, 86/59, pulse is 109, and JVD is 11 centimeters, lungs are clear, and heart sounds are muffled. What is the cause of the patient's presentation? So this patient over here has Beck's triad. We have low blood pressure, we have a JVD, an elevated JVD, and we also have muffled heart sounds. That's tamponade, cardiac tamponade. So what's the cause of the symptoms in tamponade? So there's going to be decreased left ventricular preload. Since the heart is being squashed, there will be a reduced preload, and therefore cardiac output will be decreased. It's not A. There's actually going to be an increased cardiac contractility in cardiac tamponade as a compensatory mechanism. Question 15. A 28-year-old woman at 25 weeks gestation comes in with a blood pressure of 153/89. Physical exam of mom is normal, and the baby's heart rate is 150 a minute on Doppler. Liver function studies are normal. What is the next step? So here we have new onset hypertension in the pregnant lady, and because of the potential complications associated with preeclampsia, for example, maternal end organ damage and fetal growth restriction, all patients with a hypertension at above 20 weeks gestation would require preeclampsia evaluation, and that would include a collection for total protein. So that's what we do over here, collection for total protein. Magnesium sulfate is for preeclampsia when we already know it's severe, and of course we don't do reassurance because we need to evaluate this lady. Question 16. Correcting which of the following CAD risk factors will benefit the patient the most? And the answer is actually smoking. Smoking cessation results in the greatest immediate improvement in patient outcomes for CAD, and already within 1 year.
stop playing with him. Black, stop playing with him. Black, stop playing with him.
divided by 0.
Yo, I've been on mute. What the heck? What in the world happened to my thing? Here's something. I'm getting a call right now. Which of following is the most appropriate dietary recommendations at this time for this 10-year-old boy? His parents both have hypertension and hypercholesterol. He plays a lot of sports, eats a lot of foods. You know, he drinks 2 glasses of milk and fruit juice daily. He's in 97th percentile for weight and BMI. I mean, he needs to cut down on the carbs. Here's a healthy 4-year-old boy is brought to the physician because of a 1-week history of intermittent fever. In the past 3 days, he had decreased activity and joint pain. Just had fever, and now he has a joint pain. He has a red rash on his chest. Time to take care. Adenopathy in the cervical chain, 2 out of 6 exotic murmur. Just wanted to run this to the joints. Looks like count of 50K. He has to have ALL. Now you have a 7-year-old girl with juvenile rheumatoid arthritis. She's about to her doctor because of 1 year of history of progressive fatigue. She has had occasional fever, swelling, and pain in the knees in the past month. She looks sick. Temperature, just fever. I might have to go with anemia chronic disease on this one. Let's see. Yeah, mean corpuscular volume, MCV. Oh, so she has microcytic anemia. Do you have microcytic anemia and chronic disease? No, you don't. Sickle cell disease. She could have sickle cell. Most likely diagnosis on this 14-year-old girl brought to the physician because of lower abdominal plants and intermittent pain in her knees and hips for 6 weeks. Cramps relieved by bowel movements. Since period, just 10 urgent bloody bowel movements daily. Goodness gracious. Knee joint, hemoglobin comes to 14. Wow. So she has straw-colored turbid fluid in her knee joint. Giardiasis. So most likely diagnosis in previously healthy 7-year-old boy is brought to the physician because of progressively worsening headaches and difficulty walking over the past 6 weeks. Oh my lord. Bilateral papilledema, right abducens palsy, and gait ataxia. Bilateral papilledema, abducens, the abducens, gait ataxia. Acoustic neuroma, pinealoma. I mean, that makes sense. Worsening headaches, difficulty walking. Could it be something that I don't know. Most likely cause of the findings in a previously healthy 15-year-old boy brought to the emergency because of right scrotal pain and swelling for 3 hours. Right scrotal pain and swelling for 3 hours. Sexually active 3 months ago. He did not use a condom. Tenderness and edema in the region of the right testicle. Thoracic reflex. Appropriate next step in management. Healthy 9-month-old girl is brought to the physician by her parents. First 9-month-old girl, parents convinced to in the fleet. Monthly for 50% top of weight and this growth pattern has been consistent since birth. Most appropriate next step in management. What is the next step in management for the 16-year-old girl who's had increased severe pain with her menses? To this good engagement between the concern level and gross body vomiting. Pregnancy test, and then we're going to go laparotomy later. Most likely to have prevented this patient's current condition. 9-month-old boy is brought to the physician 2 months after his parents noticed. They seem to be ignoring him. Red boys have fatigue, decreased appetite. Most primitive next step for this 4-year-old boy has fatigue, decreased appetite. My weight loss was 2 months. Feels listless. I feel like doing more questions. Keep doing questions. Dun, 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 dun. Diagnosis. 6 days after going to operation for a truncus arteritis defect. And boy, it's dirty. Looks like a causal organism. 3-year-old boy is brought to the emergency department because of one day history of fever, abdominal pain. What's the causal organism in this 3-year-old boy who was in the ED for abdominal pain, fever, diarrhea, blood, and mucus? History of recurrent ear infections, treated with antibiotics. He just had amoxicillin clavulanate 1 day ago. To say C. diff. C. diff, it don't cause bloody, right? It'd be salmonella. Because salmonella is the one that has mucus. Also, the diagnosis of an 18-year-old Montague girl brought to the physician because of a 2-week history of symptoms of an upper respiratory tract infection. Sometimes, so she's had this for 2 weeks. Over the past 2 months, she has several episodes with social media. Very broad. I haven't currently in response to sounds. Which following vaccines most appropriate at this time? 16-year-old girl comes to the physician for examination prior to participation in school sports. So she's 16. What immunization does she need? Dang, only thing she got since kindergarten is DTaP. Not too bad. Oh, hell. Get this woman. If HPV not on the list, I don't want it. Why would she need a Hep B? Does she need a Hep B booster? Show an increased concentration of which of the following hormones? 14-year-old girl is brought to the physician because of progressive tiredness during the past month. This 14-year-old girl. So she does type 1 diabetes. Regular 30 to 40 day intervals. Yo, what's good? Thought? I don't know who that is. But what's good, bro? You studying? What do you think? The flow being heavier, I mean, more estrogen makes sense. It makes sense. She has a pituitary. I don't know. so. I think estrogen will for now. Also, the explanation for these findings, and this 2-month-old boy is brought to the physician by his parents. It's 95th percentile of head circumference. How many pixels do I have? It's pretty open. So we have your PDA open. Yeah, more blood. Extra cardiac right to left shunt. That's PDA. Excess intake of which following vitamins. Most of the explanation for the 16-year-old girl's headaches that increase in frequency and severity over the past month. Non-papillary edema. Appropriate next step in diagnosis. 2-week-old newborn brought to the emergency by his parents with a 2-day history of excessive forceful vomiting after eating. Let me download a new world. Turn the Wi-Fi back on, boy. My ear's hurting just a little bit. She had a history of excessive forceful vomiting after eating. Uncomplicated pregnancy and vaginal delivery. Appeared mildly dehydrated. X-rays should be show distinct bubbles line. If it's pelvic stenosis, let's type of pathology in this patient. 2-day history. Yeah, I'm sure it's pelvic stenosis. Let me just check. I'm just gonna check the. Just gonna see what the answer is to that one real quick. does C. diff? How did it get the mucus though? And it's bloody. Oh, so the camera can bloody. I thought freaking salmonella can have the freaking mucus. I thought salmonella had freaking mucus in that diarrhea. Gonna cause osteomyelitis. Sickle cell disease, pneumonia. Reservoir on the cooked chicken. Pathophysiology for acute material bloody diarrhea. Peace and diarrhea. The side seems still. I mean, that can be inflammatory cells on stool, but it doesn't necessarily say. Doesn't necessarily say mucus. But I need to take some acetaminophen. I need to use the restroom and then take some medicine for this headache.
since I was a kid, I've been legit. If I was you, I would cut my wrist down. X so tatted all over her body. Oh, she just wanna roll and I don't mind it. Yeah. Ever since I was a kid, I've been legit. You should let it go. She wanna be it. Don't want all tatted on her body. Yeah. It don't matter what they say. I'm timeless. Yeah. City on fire. When I'm coming home, fill up the sky. I fill up the dome. We'll play it one day. It's a hell of a show, but it's gonna hurt, 'cause we did it first. Feel like skateboarding. BBC boys on creep. Feel like it's on free. Neptune done with the beach. She would be flipping out. She wanna fuck with the team. She fell in love with the team. She fell in love with the sea. Hold on quiet, not a beat. Broke his heart, PTSD. Hold his chest, let it be. In this scheme, I got a piece, and we got a pause. Get out of line, turn into a guy. I shed a tear, if I were lost, so yeah. Ever since I was a kid, I've been legit. If I was you, I would cut my wrist. X so tatted all over her body. Oh, she just wanna run and I don't mind it. Yeah. Ever since I was a jit, I've been legit. Oh yeah. You should let it go. She wanna be it. Oh no. Don't want all tatted on her body. Yeah. It don't matter what they say. I'm timeless. Timeless. Oh, timeless. 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 We timeless. I'm timeless. 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 Timeless.
Turn my headset off. Got some oatmeal, cinnamon, vanilla, oat milk, freshly diced apple, a little bit of salt, a little bit of honey. Yo, my head is hurting so bad. I think I'm done studying. I want to go on longer, but my head's hurting me. Got these 6 more questions to go over. All right, y'all. GG's. Nice steady session. I gotta pack it up because my head is killing me. Y'all enjoy.